Hello, my dear friend. A very warm welcome to all of you. In this session, we will discuss some important topic within next 2.5 hours. All the 5 important topic: nutrition, vaccination, environment, epidemiological concepts, biomedical based revision I will do, and some biostats area also we will cover. So let's start with this one question. They will ask that there is a female of weight, let's say 65 kg. How much protein is needed per day? You must have seen those ad of Akshay Kumar where he jumped from the kitchen and say, whatever is your weight, eat 1 gram protein per day. Let's say if I took that advice seriously, my weight right now is 95 kg. I started taking 95 gram of protein, then there will be more part hanging from my body. So we don't advise patient like that. This, what is your weight? Take 1 gram per day according to that. No. There were 2 errors in that ad. First error is we only give 0.83 gram per day protein, not 1 gram. And second is all the advice which we give to patient is according to reference male and reference female. And as you all must be knowing, and you should remember that reference female weight is 55 kg and reference male weight is 65. So the protein needed is 55 multiplied by 0.83 for all the female who are listening this class. And for all the male who are listening this class, the protein is 65 multiplied by 0.83. So if you multiply 55 with 0.83, it will roughly come around 46 gram or 45 gram. And if you multiply male weight 65 with 0.83, it will come 55 gram. So that means very simple, no matter whether they give 65 kg weight or 95 kg weight like me, the protein requirement for all the female will be same, which is 10 minus their reference weight. Their reference weight is 55 and 65, 55 for female, 65 for male. So the protein needed for female is always 45, no matter what is their weight. And the protein needed for all the male is always 55. Okay. Other than that, they can ask you the height. The difference in weight is of 10. The difference in height is of 15 centimeter. It's 177 for male, 162 for female. BMI they have never asked, but if they ask, it is 20.95 for reference female and 20.75 for reference male. And it should range between 18.5 to 22.9. So only till 22.9 you are normal. After that, you are pre-obese. Pre-obese for Asian WHO classification is 23 to 24.9. That means roughly 23 to 25 is pre-obese in Asian classification, and more than 25 are obese in WHO Asian classification. Hello Lalit, hello Lau. I hope you are enjoying the session. Thank you for being here. Let's continue this point. The age which is there for reference male and female is 19 to 39. Just to include me in this category, they have increased the age. Previously it was 19 to 29, but now it's 19 to 39. And they should spend 8 hours in bed, not necessarily together, 8 hours of sitting, not necessarily on each other, 4 to 6 hours of moderate work, not heavy work together, and 2 to 4 hours of creative or household activity, which I think they should definitely do together. Now, let's come to the energy requirement. It's very easy. All the female listening this class, if you are preparing for NEET PG, mostly you are sedentary, mostly, not all. So then your energy per day is 1700, and all the male, including me, are sedentary right now. So we will be 2100 kilocalorie, mostly, if you are not on duty or something. 1700 and 2100 is our calorie. If you remember that, it's very simple to remember the rest part. Just 2100, 2700 is for moderate and heavy worker female, and the same 2100, 2700 goes to sedentary and moderate worker male. When it comes to heavy worker male can be a farmer or a laborer. So we give them double the energy. Double of 1700 is around 3400. But because they are farmer or laborer, we will give 100 kilocalorie extra, and total there is 3500 kilocalorie for heavy worker male. And roughly remember, this 3500 is one thing which they ask usually. And other than that, remember our calorie 1700 and 2100. Now, extra energy per day in pregnancy, pregnant female like me will take 350 kilocalorie extra, and lactating female needs 600 kilocalorie extra. This question has been asked twice. Do remember, whenever we talk about RDA RDA fulfill need of 97.5% population. But when we talk about estimated average requirement fulfill need of 50% population only. So which one will be bigger? RDA will be bigger than estimated average requirement. Then other than that, they ask about calcium sometime. Calcium for all adult male, female and pregnant female is the same 1000 milligram. But in lactation, we need it more 1200 and old age is same 1200. Vitamin D is same needed 600 international unit in every age group. They can ask iron. Remember, iron is needed more in adult female as compared to pregnant female, because adult female are going for menses loss, but in pregnancy there is no menses loss. So adult female will need 29 milligram, pregnant will need 27 milligram. If they ask iodine, iodine is 150 microgram in adult male and female. It is 250 microgram in pregnant, 280 microgram in lactating. So 250 and 280 are the iodine requirement in pregnancy lactation. Now, other than that, in biochem, they ask this question from glycemic index. Glycemic index simply means then that when we eat 50 gram of any other food, then our blood glucose will rise, and we will compare that rise in blood glucose with 50 gram of glucose. And because we all know, if we eat 50 gram of glucose, then our blood sugar will rise most quickly. So this uppermost is 50 gram of glucose. We put this 50 gram glucose denominator, and in the numerator, we compare it with the food that we are eating, 50 gram of that food. And then we multiply by 100. So that is why it is always less than 100, because no food can raise your blood glucose parameter quickly than glucose. So it's always less than 100. Now mainly, sorry, they ask you about the different category of glycemic food. In medium, remember the cutoff 56 to 69. 69 is something which denotes equality. So remember, 56 to 69 is the cutoff for medium glycemic index. In non-communicable, we will read that 69 is also the cutoff for intellectual disability. Now we don't call mental retardation. Otherwise, people understand. If you call them mentally retarded, they will understand. If you call them intellectually disabled, they will think you are calling them intelligent, and they will not understand. So do remember, intellectual disability is the new word in place of mental retardation. The cutoff is 69. And if it is 51 to 69, it is mild intellectual disability. If it is 36 to 50, it is moderate. If it is 21 to 35, it is severe. And if it is less than 20, it is profound. So how to remember this cutoff? Because in PSM, in psychiatry, both area they ask it. Very simple. Last one is 20 and first one is also around 20. Cutoff is 69. 2020 is mild and profound. In between these two have cutoff of 15. Okay. Now, when it comes to high glycemic index food, we all know those who raises our blood sugar very quickly. They will be cola, chips, fried food, potato, jasmine rice, sweet potato, sakarkand, that all those food come under high glycemic index. When it is low glycemic index, these are the good food, so-called pulses, pasta, but not the one with so much of mayonnaise, millet, fruits, except sweet potato and watermelon. So do remember, more than 70 is high, 56 to 69 is medium, and less than 55 is low, and under medium we have jasmine rice. Now, they can ask what is prudent diet. It is that diet which is given to cardiovascular disease patient, and in prudent diet, salt intake is less than 5 gram. Now they are also saying that sugar intake should also be less than 5 gram. Other than that, saturated fat should be less than 10% of total energy. These two things you have to remember. Salt and sugar less than 5, saturated fat less than 10, and daru ban, no alcohol. Of course, we should not take processed carbohydrate. Other than this, they can also ask one more thing. What is in a high fat diet? That's an PYQ of INICT. High fat diet is something which has total calorie around 1000. And out of this 1000 kilocalorie, 50 to 60% is fat. That means fat is giving around 600 kilocalorie out of this 1000 kilocalorie. So carb and protein, they only constitute around 40% of remaining kilocalorie. That means carbohydrate cannot be more than 300 kilocalorie and protein can also not be more than 300 kilocalorie. Fat will be around 600 kilocalorie and total will be 1000 kilocalorie energy. Do remember about high fat diet. Now they can give you the image of a child with protruded abdomen like me, but they can also show you the ribs at the same time. And they will ask, this child is due to deficiency of energy, protein, or both energy and protein. And usually students do the mistake and they take both energy, protein. No, if it is both energy, protein deficiency, it will become marasmus. So here the answer is only energy deficiency, not both. And second thing is that, here the answer is only protein deficiency, because we all know energy deficiency is not in a fatty diet, not in a fatty child. This child is having protein deficiency which lead to Kawasaki-Yorker, and because there is protruded abdomen, so it is Kawasaki-Yorker. Of course, in Kawasaki-Yorker we see flag sign. So the student who was writing it, when I said flag sign, he put a real chudki, real flag. Now, that's not flag sign. Flag sign means the hair, some hair will be brown, some hair will be black. Due to lack of protein, hair will be brown and then black. So it will look like flag on the head. But more common question they ask is, who will have fatty liver? Fatty liver is in Kawasaki-Yorker. And one more thing they ask, is the Kawasaki-Yorker child interested in eating or not interested in eating? So Kawasaki-Yorker child is not interested in eating because of lack of protein. He is unable to absorb other nutrient also. There will be fatty liver, flag sign, pitting edema in Kawasaki-Yorker child. And you know the rest about marasmus. Now, one more thing which can occur if there is deficiency of essential vitamin, essential fat soluble vitamin like vitamin A, D, E, K, or deficiency of essential fatty acids. Then the disease will be phrinoderma, and they can give you image of a rough dotted black skin. That is phrinoderma. Now, when it comes to protein, they can ask the quality of protein is indicated by which thing? So that is net protein utilization. It's a very simple thing. Whenever you go to gym, the first thing they will ask you to eat egg white. So let's say I went to the gym and the first day I went there, they said eat egg white, and I took 17 egg in the same day. And one egg give around 6 kilocalorie energy. So when I eaten 17 egg, from 17 egg, I got roughly 100 gram of protein. And I eat so much of egg that I started looking like an egg myself. So 17 egg gave me 100 gram protein. Out of that 100 gram protein which is present in food, how much protein my body will utilize? 96 gram. And only 4 gram will go away from my body. So out of 100, I utilize 96 gram in making muscles, hormones, enzymes, and other things. That is why they say net protein utilization of egg is maximum 96, and that is why egg is best quality protein. So what is NPU? Utilized, protein utilized as compared to protein present. Utilized as compared to present. That's why they call it net protein utilization. The other formula of NPU is it is digestibility coefficient into biological value by 100. Why? Because if you multiply these two things together, digestibility coefficient and biological value, this protein absorbed is common, it will cancel out. And if protein absorbed will cancel out, finally we have protein utilized in the numerator divided by protein present. And protein utilized by present, you can see protein utilized by protein present. This is the formula for NPU. But NPU have only 100. And if you multiply these two, there are one extra 100. So to remove that extra 100, we are dividing DC and BV with 100 to remove that extra 100. So do remember, NPU is utilized by protein present, and it is DC by BV into 100. Other than that, you should know that although egg has high quality protein because of high NPU, soya bean is the one with maximum protein, that is around 43 gram of protein in 100 gram soya bean. But soya bean has less biological availability, so it is not well absorbed by body. Fish has maximum protein energy ratio, which is 80%. So suppose आज मैंने एक बड़ी मच्छी खाई. I eat a big fish today which gave me 1000 kilocalorie energy. Out of that 1000 kilocalorie energy from fish, around 800 kilocalorie will only come from protein of fish. Remaining 200 will come from carb or fat, but 800 is directly protein. That is why fish has highest protein energy ratio. Total energy I got is 1000, out of which protein of fish gave me 800 kilocalorie energy. And you can see it yourself. If you remove the skin of fish, it's directly protein which is inside. And so 80% of energy which we get after eating fish is directly protein. So do remember these 3 points separately, that fish has maximum protein energy ratio. 7-8 years back, I was a vegetarian. But then I fall in love with a girl who eat non-veg, started eating chicken from biryani, and nowadays I even suck the bone marrow and all. So love can make you do crazy things. Now let's come to this second component, which is we read about milk and egg because a lot of questions come from them. And then we will read about vitamins and food adulteration in nutrition. So first thing is, one egg gives us 60 to 70 kilocalorie of energy. And it has 6 gram protein, 6 gram fat, 250 milligram cholesterol. And egg are deficient in vitamin C. Okay. When it comes to human milk are more deficient in vitamin K. Human milk don't have vitamin K. That is why vitamin K is given as injection. As soon as the child is born, we give 0.5 ml of vitamin K intramuscular. So that is because human milk don't have it. Then they ask, which of the following is maximum in human milk? Carb, protein, fat, iron, calcium. Answer is carbohydrate is maximum in human milk in the form of lactose. Along with lactose, water, which is 88% of human milk, then taurine, 16 amino acid, and DEA. These all are maximum in human milk. So who have maximum fat, protein, iron, calcium? All of these are maximum in buffalo milk, because remember it, no one can beat a bhaisia and no one can beat a buffalo. So do remember, when it comes to protein, buffalo have maximum of protein, iron, calcium. After buffalo, there is goat. After goat, there is cow. And after cow, there is human milk. This is the sequence for protein, fat, and iron, calcium. So this sequence is very easy to remember. Buffalo, goat, cow, and then human. Human has maximum lactose, but not other thing, which is maximum in buffalo. Now, what is the most essential amino acid if they ask? Answer is very simple, linoleic. And second essential, linolenic. How will you remember it? Very simple. If there is one N in linoleic, it is in first position. And if there are two N, like in linolenic, it will be in second position. The third essential amino acid, essential fatty acid is arachidonic acid. Okay. Now, which prevent people from heart attack? Omega-3 fatty acid prevent from MI heart attack. Which is the best source of vitamin A, D, E, K? That is fish liver oil or halibut liver oil. Which is the richest source of vitamin C? That is amla and then gooseberry. And which oil has maximum essential fatty acid? Very simple to remember. The ad which we see commonly is of Saffola. So safflower oil has maximum essential fatty acid. And which oil has maximum saturated fat? That is coconut oil. If there is deficiency of essential fatty acid and ADEK vitamin, that is Trichoderma, which will occur, which we have discussed. Most commonly, they ask question from vitamin A and they confuse you there. They will ask, what is the first sign of vitamin A? And people write night blindness. No, night blindness is the first symptom which doctor will see in the patient. Is the sign. And what patient come and tell us is the symptom. So patient will come and tell us about night blindness. So night blindness is the first symptom. But what we will see, doctor will see in the eye of patient first, that is dryness of conjunctiva, conjunctival xerosis, which is known as sand on tide appearance. So conjunctival xerosis is X1A, first sign. Second sign is bitotic spot. After bitotic spot, which is X1B, we have corneal xerosis. Then corneal ulcer will occur. X2 is corneal xerosis. Corneal xerosis. Then X3A is corneal ulcer. X3B is also corneal ulcer. Corneal ulcer less than 1/3 is X3A, more than 1/3 is X3B. After corneal ulcer, we develop corneal scarring. Then we develop night blindness, and after night blindness, there is scarring of retina. So they can ask which thing we use as screening for vitamin A deficiency. And we cannot use vitamin A for screening because We cannot use night blindness for screening, because when night blindness occur, till that time retina has also dried. So we cannot use night blindness as screening. We use for screening which thing? We use for screening Biostats spot. Okay. Now, one very common question they ask is, when will you decide to give vitamin A to all children in an area? If you want to give vitamin A to all children, night blindness should be more than 1%, Biostats spot should be more than 0.5. How to remember it? See, night blindness is the one which is reported by patient. So it should be more, because it is easy to report, 1%. Biostats spot is a screening thing, which we will go and screen. So Biostats spot is 0.5, okay, percent. Another way is alphabetically after A come B. So B is the second letter, and it is half the population which should be there with Biostats spot. Then we give vitamin A to all the children in that area. So Biostats spot 0.5 and night blindness 1%. Don't confuse there. It's an expected PYQ for your upcoming NEET exam. If I will say, this is a very expected PYQ. Okay, this classification. How do we decide to give vitamin A in the whole population? Now, if night blindness occur or any vitamin A deficiency, gerophthalmia occur, in gerophthalmia treatment, we give 3 doses on day 0, 1, 14, today, tomorrow, and 14 day. If the age is less than 1 year or weight is less than 8 kg, if any of these two criteria is there, we will only give 1 lakh. We will give 2 lakh only if weight is more than 8 kg. So they will ask this question: weight less than 7 kg, age 1.5 year, what will you give? So no matter what is the age, if weight is less than 7 kg, we will give only 1 lakh international unit of vitamin A. Okay. Now, let's talk about vitamin B1, which is thiamine, which do occur by eating polished rice with this thiamine deficiency, and they can give you clinical feature that patient have breathing difficulty and feature of pitting edema on leg and dependent part, like CHF feature. That is wet beriberi. Dry beriberi, neurological symptom, they will give patient history of difficulty in walking, spasticity and all. That is dry beriberi. They have asked it in NEET just last year, that which enzyme is deficient in this patient of wet beriberi. The enzyme deficient is thiamine transketolase enzyme. Okay, do remember the name. Now, Irfan is saying that please provide the PDF after the class get over. Without PDF, it is very difficult to revise. Okay, Irfan, we will do it. We will do it, only then we will leave the area, and after forwarding it in my Telegram group. And Rohit Kawate is saying you are doing great job taking this class before exam. Thank you, Rohit. And it is mutually beneficiary also. I am also getting my YouTube channel being viewed by you, so it is good for me also. But of course, if you are listening it carefully, these topics in just 2.5 hours, these topics will fetch you a lot of marks in your exam. Okay. Binu is saying, speak slower, we cannot understand. Sorry, Binu, but whatever you do not understand, just let me know. Covering these so many topics in 2.5 hours can make us speak a bit fast. But I will clear your doubt. If you have any doubt, let me know. Okay. What is cornea? Is the question. Cornea is one of the structure in the eye. We start with conjunctiva first, which you cannot see. It's a slimy layer. After conjunctiva, whatever is visible, that white part, you know, that is the sclera and all. And then in the center, the black dot is the iris, and then pupil is around that, and around that there is cornea. So its optal base is needed, but it's behind conjunctiva, you can see. So first there is conjunctival xerosis, then there is corneal xerosis, which will occur. Now, let's do this one question they have asked, that if there is deficiency of B2, there is angular stomatitis, and where there is cracking of the corner of mouth. But if there is someone who is eating raw egg white, which deficiency will occur? So raw egg white has avidin protein, which bind with biotin and lead to biotin deficiency. So last year in NEET 2023 only, they have given image of a child with red colorless hair. So that was, and history was given eating raw egg white. So that was biotin deficiency. Now, one more thing I want to tell you is that they can ask you in this NEET 2024 about zinc deficiency. If they ask zinc deficiency, they can either give you the symptom of hypogonadism, which occur with zinc deficiency, or they can give you dryness around nose or mouth. Okay, this second thing will occur. Then the third thing which can occur with zinc deficiency is zinc deficiency can also lead to delayed wound healing. So all these three has been asked already: delayed wound healing, hypogonadism, dryness, and then low birth weight baby, preterm delivery. This can also occur with zinc deficiency. But zinc deficiency do not come under Rashtriya Bal Swasthya Karyakram, because it is very difficult to find these symptoms in most of the patient. Zinc deficiency is hidden. Only in some 10% patient these symptoms are being identified when zinc deficiency become very severe. Okay, so do remember all these things about zinc deficiencies. Okay. Now, vitamin C, we all know if there is deficiency of that, there will be bleeding gum. Today morning itself I had bleeding gum, so I thought of taking some vitamin C thing. What disease I can have? I can have scurvy, which is collagen synthesis defect. Okay. Plus, when we will talk about adulteration, they can give you this question that patient are walking cross leg on toe, or they can give you the history that someone come from Chhattisgarh and there is history of poverty, eating only rice and pulses, and there is history of spasticity or difficulty walking, neurological symptom. So if any of these is given, difficulty walking, spasticity, Chhattisgarh or Bihar, poor family, all these things, if they have given in the question, mostly it is pointing towards neuroletharism. And in the neuroletharism, the treatment which we give has been asked in NEET last year, that is vitamin C 500 to 1000 milligram for 1 to 2 weeks. And they have also asked in the same NEET exam last year, what was the poison which caused this problem? So the poison is beta-oxalyl aminoalanine, which can be removed by paraboiling, keeping the khesari dal in bleaching powder water for overnight will remove the poison boa. So why this problem occur? Because khesari pulses are eaten by some people, and in some places they mix it with arhar pulse to lower the price of arhar pulse. Second food adulteration they can ask is liver cell carcinoma is there after eating contaminated groundnut. So if it is contaminated groundnut or maize, it has Aspergillus flavus fungus which release the toxin aflatoxin. Third thing they can ask is patient have cyanosis necrosis of finger after eating black color wheat or rye with Klebsiella purpurea. What is the poison? That is ergotoxin. But most confusion occur in these two things. If there is endemic ascites, it is due to eating crotalaria plant with Panicum miliare, and the poison is pyrrozolidine. So we all know in ascites there is swelling of abdomen, पेट फूल जाता है. Abdomen is roughly known as पेट. In Hindi we call abdomen as पेट. So in ascites there is abdomen swelling. So in ascites the poison also have starting with P, because P for pate, abdomen. So pate is getting swollen here in ascites. We all know ascites, pate got swollen. So poison is also from P, pyrrozolidine. Now second thing is epidemic dropsy. Very, very commonly asked. It is one of the expected PYQ which I can think this time from expected to come from this dropsy. In the dropsy part, what happened is, if you are eating mustard oil, and we all are eating mustard oil, and it is contaminated with seeds of Satyanasi, Argemone mexicana, the destroyer. So then this Argemone mexicana, it grows in the beautiful yellow field of mustard, and the seeds of Argemone mexicana is also same as seed of mustard, black color seeds are there. So sometimes it gets naturally mixed, sometimes people mix it to lower the price of mustard oil. And the poison which is released is sanguarine from this Argemone mexicana, which lead to bilateral pitting edema on leg and then congestive heart failure like symptom in patient. So how will you remember it? To remember it, now we can again take the first letter here. First letter is S, and S stand for sung. S stand for sleeping, and there is again one word sung. Sung means together. You know? So anyway, you can take S for sleeping. So if you are sleeping together with someone of your dream, first thing is you will not sleep. But if you sleep, there will be dropping of eyelid. So S for sleeping, and there is dropping, dropsy, which is occurring. So when does dropsy occur? Dropsy occur in that poison which has S or sleeping. Second thing is the symptom is also dropping, pitting edema. So you can remember it from there. Pitting edema, dropsy, due to sleeping. So the poison is sanguarine and a dropsing of eyelid and all. So poison sanguarine in epidemic dropsy. Don't get confused there. Pyrrozolidine, ascites, pate. Sleeping, sanguarine, dropsy, pitting edema. Okay, mustard one. So don't get confused here and do remember it. Now, after doing the topic of nutrition, let's just in next 3-4 minutes revise the topic of this biomedical waste. Do remember, they can ask you that if there is plastic wrapper of syringe, as soon as we think plastic wrapper, we think it is to be thrown in red, but all the garbage goes in black, and wrapper of syringe is without blood, so it will also go in black along with doctor prescription or any other leftover food product and all. So black is for garbage. And if you remember yellow, you will not be mistaking here. So to remember yellow, just take an example. Suppose after taking this class, I am going outside and I have a red road accident and my injured body came to you and you cut both my leg, and now only some part is hanging in between. Where will you throw my leg, the anatomical waste, in yellow? The blood which will come out from it, where will you throw those liquid? Again in yellow. And due to that blood, the bedsheet pillow cover will get soiled. Soiled means dirty. So where will you throw the soiled waste? Again in yellow. You will give me some medicines and drugs, and all the medicines which are left over or expired or discarded, that will also come in yellow. Then you will take my blood sample for confirmation that which drug will work or not on me by doing drug sensitivity test on culture medium and all. So all the microbiological waste will also come under yellow. So 5 things are there. Last thing is cytotoxic drug. These 6 things come under yellow, and yellow should be on tip of your tongue. कोई पूछे तो एकदम थूक की तरह निकलना चाहिए, and it should come like sputum redly, and it should be on tip of your tongue. 6 things, and you will not be confused in this topic. Now they can ask you what is the best method of disposal of cytotoxic drugs. So for cytotoxic drugs, there is separate yellow wooden box in which we put it, and then we send it back to the manufacturer who have given it to us. Third thing they can ask you from yellow category is how we dispose the waste. So the incineration or burning is the way by which we dispose yellow, but in PHC and all, there is no incinerator plant, so we dig a pit and cement it from 5 sides and throw yellow category waste in it, then let some dust deposit over it. That is known as deep burial, which is at PHC for yellow category. Red bag will have plastic and rubber under it, and we first autoclave it, then we recycle it. Blue bag will have all the instrument and glasses under it, and implants will also go under blue bag. But when they ask white bag, just remember 4 things comes under white bag. One is needle with fixed syringe. Second is scalpel, because in the scalpel we cannot remove the blade. It will cause hurt, and once blade is used, the edge is blunt. So scalpel we have to dismantle, cut into small pieces and throw, not use it. So in white we only throw those things which we need not to use again. So of course sharp thing goes under it, but under sharp only 4 things goes under it. Scissor will go in blue because we have to reuse the scissor. And in blue category, whatever we throw, after autoclaving, we reuse all those metallic instrument and implant. So white category is for those things where we have to dismantle it. Needle with fixed syringe, scalpel, all needle, all blades come under white. Now, let's do some question which has been asked previously. One of the very controversial question is about broken vaccine vial, where it goes. So Park has clearly written it that if there is broken cytotoxic drug vial. Cytotoxic drug vial will go in yellow. But other than cytotoxic drug vial, all other vial, because vaccine is not cytotoxic. Cytotoxic are anti-cancer drugs and all. Cytotoxic drug vial will go in yellow, but other will go definitely in blue. And it's being written there. Second thing is, pacemaker being metallic goes in blue. Acrylic gloves or any gloves, let's say there is gloves with some blood on it, that will also goes in red. Because most of the gloves have some blood stain. If you throw that much of plastic in yellow category, then in yellow we burn them, and burning this much of plastic will not only produce pollution but also polyvinyl chloride, which can cause liver cell carcinoma. So we cannot burn all those gloves with a small blood stain. And anyway, in red we are first doing autoclaving to clear those thing, and then we recycle it. So glove with blood, any kind of gloves will go in red. Cotton definitely go in yellow, used or unused does not matter. Blood bag goes in yellow, urine bag goes in red. Very simple to remember. Lal mein peela, peele mein lal. And a red color blood goes in yellow, and yellow color urine goes in red. Now, red in yellow, yellow in red. Like that you can remember. Ryle's tube or any tubes also goes in red because it is plastic. Culture medium definitely goes in yellow, but people confuse in culture plate. They think it is glass, so it will go in blue. But Park has written all culture medium and culture plate Petri dish will go in yellow. So culture plate also goes in yellow. Other than that, if you have any question where to throw anything you want to throw, let me know and we will classify it according to our concept. Now, okay. Irfan is saying, sir, please arrange some more such classes. So, okay, we will have class on Wednesday also, and then probably on Thursday also. Wednesday, Thursday, Friday, 3 days, I will probably take more classes in which we will revise the INICT question also to give you extra edge. The remaining topic, whatever is left out from today class, we will take one session for that. And in 5 hours, I will try to revise all the PSM 2.5 hours today for these 5-6 topics. BMW, Nutrition, Environment, Epidemiology, Biostats, and then next 2.5 hours for remaining topic. So like I will have 2-3 more sessions for sure. Chalo. Now, Irfan is saying repeat white and blue bag. Why not, dear? It's very simple. In white bag, if you remember, only 4 things goes. Needle with fixed syringe, scalpel, all needle, all blade. These are for white. Remember white separately. All other sharp thing goes in blue. And these 4 sharp thing goes in white. So then in blue we have glasses, we have metallic instrument and metallic implant. 3 things in blue: glasses, metallic instrument, implant. 4 thing in white: needle with fixed syringe, scalpel, needle and blade. Okay. Now they can ask you about PPE kit. So real PPE kit made up of plastic, and plastic thing goes in red. PPE kit goes in red, and PPE kit do not involve apron. We remove apron, then we wear PPE kit. Second thing they ask is that if there is blood spill on floor, what will you do? So first step, if there is blood spill on floor, first we wipe it. After wiping it with cotton, then we put then we put sodium hypochlorite. This is the WHO guideline that first we wipe, then we put sodium hypochlorite. The concentration of sodium hypochlorite written in WHO guideline is 0.5%, but written in Indian guideline is 1%, and you have to follow Indian guideline in your exam. So you will write 1% sodium hypochlorite. And first we wipe, after wiping we put 1% sodium hypochlorite. Second thing, we can also use 0.5% sodium hypochlorite for cleaning the surface where the patient is living, like table or doorknob or all. And what is the best method of disposal of mercury? Again, the same: collect and recycle it or send it back to manufacturer. For cytotoxic drug, we send it back to manufacturer. But if you cannot send it back to manufacturer or recycle it, then the second best method is inertization. It means mixing the waste with cement and lime. So if you mix it with cement and lime, it will not contaminate water or environment. It becomes inert, non-infective. So it is used only for pathological, cytotoxic, radiological waste, this inertization. Finally, there is one more method, screw feed technology. in which we put the plastic waste and cut it into fine pieces, pulp of plastic. This will not only reduce the volume of waste, it will also reduce some weight of the plastic waste. But of course, secure screw feed technology is of no use for cutting anatomical waste. What is the use of cutting my leg into fine pieces? And it will be difficult to manage. So screw feed is for plastic or red category mostly, and inertization is for yellow category mostly, where we mixed inertization, pathological cytotoxic radiological waste, PCR waste with cement and lime, 15%. Okay. Now, there is one more thing which we will read in environment chapter, secure landfill control tipping. This is the best method of disposal of kitchen waste. What we do in this is, we like when we were a kid, we had a big area in front of our house. They dig a pit and ask us to throw our kitchen waste in it. So when you used to throw some kitchen waste, some soil used to deposit, some more kitchen waste, some more soil, and after 1 year it became a plain surface area and we used to play badminton over it. So that is control tipping. We were throwing our kitchen waste slowly. We were tipping it in a control manner. And when you throw it in a control manner, it will fill the land in a secure way. It will not contaminate the surrounding. So best for kitchen waste is control ticking sanitary landfill. But if they ask you this question, and they have asked it in UPSC, that what is best for night soil? Night soil का मतलब होता है टट्टी. Night soil means feces. Best for feces and kitchen waste both. So if they add both, then the answer of choice will be composting for both. But if they say only kitchen waste, then answer best is secure landfill or sanitary, secure landfill or control tipping. Okay. So now with this, we finished biomedical waste also. If you have to throw something which you are not sure how to throw, we can do it again. And the biomedical waste is done. Now, after biomedical waste, we can move to the topic of vaccination and environment. So let's first do vaccination, then we will do environment. In vaccination, first thing is, they can ask you the question from National Immunization Schedule. Like they always ask, in last NEET also they have asked that at 10 year, which vaccine we give? So 10 and 16, we give DT, diphtheria, tetanus. Nowadays TT is not given, DT is given. So 10, 16, DT. Then, how will you remember the whole vaccination schedule? So to remember the whole immunization schedule forever, just keep doing this 3-5-3-5. देखो 3-5 करने का है, and you will remember the whole immunization schedule. First thing is, what are the 3 vaccines given at birth? OPV, zero dose, BCG, and Hep B. 3 are given at birth. And for all these 3 things, ASA don't get paid. Because ASA is getting paid for motivation of the mother for vaccination, and at birth, mother and mother-in-law are in the hospital. So whom the ASA will motivate? Father-in-law, Sasurji. There is no one to motivate at home. That's why ASA don't get paid for these 3, but ASA get paid for all other vaccination. It is not a work of ASA to give vaccine. ASA don't do 3 work. She don't make malaria slide, she don't conduct delivery, she don't give vaccine, but she is still paid for these work. Okay. Now, so we start with 3 things, mother, father, and child. And then you will read that at 5 year again, there is 3 things which we will give. So at birth, 3 things. Then 6, 10, 14 week, we give OPV, Rota, Penta. OPV, Rota, Penta, 6, 10, 14. OPV, Rota, Penta, 6, 10, 14. And this 3 is there for sure. OPV, Rota, Penta. Then I have we have 2 new things, FIPV, PCV. FIPV is fractioned inactivated poliovirus, not fucked IPV. And this FIPV and PCV we give at 6. We don't give it at 10. We directly give it at 14, and then we give it at 9 months. So FIPV, PCV, 6, 14, and 9 months. First, try to remember this black part separately. If you remember it into 2 fragments, you can easily remember it forever. Now, after remembering till this part, in the 9 month, We add 3 more vaccine, which is vitamin A, MR, JE. And see how easy it is to remember. The same vitamin A, MR, JE, which is given at 9 months, is also given at 16 to 24 month, which is usually we call the patient at 18 month, but we can give it any time between 16 to 24 month. So the same vitamin A, MR, JE, 9 month and 18 month. Then at 18 month, we add 2 things, DPT and OPV booster. And the same booster goes to 5 years. So it is easy to remember. MR, vitamin A, JE at 9 month and 18. DPT, OPV at 18 month and at 5 year. And then last thing at 5 year is the last dose of vitamin A. So everywhere it is following the sequence of 3, 5, 3, 5, 3, 5, except 9 month. 9 month was 3. But now they have added 2 more things here, FIPV, PCV. So 9 month is disturbing the flow. Yahi bhadwa hai. And this is the one disturbing the flow. Otherwise, all are in 3, 5, 3, 5. And I hope you can remember it separately. And do not forget, 10 year and 16 year, we give DT. Other than that, we also give 2 DT or TT anytime during pregnancy. Anytime means anytime, even in first trimester, we can give tetanus according to national guideline. But the gap between these two should be 4 weeks between 2 doses. And if mother took 2 DT in last 3 years, then we give only 1 booster DT or TT. Okay, then we don't give 2 doses. We give only 1 dose. And is it clear to you? 2 DT, but if taken 2 DT in last 3 years, then only 1 booster dose. And of course, as soon as child is born, we give vitamin K, 0.5 ml. IM. Now, let's talk about the various site where we give it, because they have asked this question, where do you give JE vaccine and what is the route by which we give JE vaccine? So JE vaccine, nowadays in India, we are using the live strain only, SA14142. The older strain, killed strain is Nakayama. Nakayama is given IM, but it is not in use anymore. You can check it from PARC also. They have written it clearly that now we are giving live vaccine. So Nakayama is Nakamyab, not given. How we give live vaccine? Subcutaneously. Measles is also given subcutaneously. J is also given subcutaneously. Now the question is, which one is given in left arm? Which one is given in right arm? So simple to remember. M for MR, M for mother love. And mother love is always right now without any expectation or something. So mother love is right. That's why MR is given subcutaneously in right arm and JE is given in left arm. Okay. Then these two are subcutaneous. JE left, MR right. Then by nasal route, we give influenza live vaccine. Other than that, Incovac and Zydus Cadila is also given by nasal drop, but they will ask, if asked, they will ask influenza live vaccine by nasal drop. So, nasal and subcutaneous we done. Intradermal, there is 2 vaccine only given. One is the BCG. And when we give BCG, the patient will come to you and say that, sir, you gave BCG in such a way it lead to abscess formation. That's why you have to tell it earlier that when we give BCG, 2, 4, 6 week, abscess ulcer scar will occur. 2, 4, 6 abscess ulcer scar. And the dose of BCG previously was 0.1 ml. But if you give this high dose, it can lead to osteomyelitis or lymphadenitis because it's a live virus vaccine. It can go to lymph node or bone causing the infection there. So nowadays we are not giving 0.1 ml, we are giving 0.05 ml and that too also only at birth. Okay. So BCG 0.05 ml at birth we give. And this BCG is given, of course, in left deltoid. So the second vaccine which is given intradermal is FIPV. Left side is busy for 6 weeks. So FIPV is given on right deltoid. So left BCG we all know. And that's why tuberculin test is also done in left forearm. And we observe tuberculin test after how many times? 72 hours. Ideal time 72 hours. And right deltoid we give FIPV. One more thing I want to tell you is sometimes they ask when do we give false positive or false negative in tuberculin. So very simple to remember. False positive is for the thing for which we all are positive. We all are positive for BCG vaccine. So false positive in tuberculin when there is history of BCG vaccine. False negative in tuberculin is for what we think we are negative, HIV. So HIV, immunocompromised, malnourished, they will be false negative in tuberculin because in HIV there is no antibody to react. So even if I have TB, HIV both, no reaction will occur because I don't have any antibody to fight and cause the swelling. Basically, just remember, false negative in tuberculin for which we are negative, HIV, false positive in tuberculin for what we are positive, BCG. Okay. Now, intradermal we read, SC we read, nasal we read. Oral route is for 3 vaccine, OPV, rotavirus, typhoral, and rest all vaccine are given by IM route. So I hope route will be clear. After this route and schedule, some in one INICD they have asked what is the composition of pentavalent. So pentavalent is definitely Hib, Haemophilus influenza type B, hepatitis B, and then there is diphtheria, pertussis, tetanus, DPT. Okay. One clinical question they can create is that there is a child who took 6-week vaccination and then he came back after 5 months. So if someone is coming at a gap of 5 months, what will you do on the next visit? Option A, will you restart from first dose? Option 2, will you continue from remaining dose? So do remember, if the child come back within 1 year, we don't restart, we continue with second dose. And here the gap is only 5 months, less than 1 year, so we continue. Okay. Now, second thing is, they can ask you about one of the student, my drug of choice is saying, sir, now Kolar strain is used in JEE. My dear friend, any update which is not given in PARC, except for some program which has been started and not given in PARC, no other update are being asked. So till PARC will change strain SA1414 into Kolar, we will not write Kolar or anything. Because the question setter, the teacher, they will create question from PARC textbooks. So they will not check Google or updates before preparing it. So if they ask what is the strain of JEE, you still have to tick SA1414 to the live virus strain. Okay, dear? I don't want to prove you wrong. You might be right also. But focus on PARC textbook only because updates are hardly being asked. Tell me any update in last 5 years which has come. It's very rare that they ask update. And update is one way of catching student attention, but it is rarely being asked. They have never asked IMR, MMR, under 5 mortality data, what is for India. They never ask this because they know all this data are mostly manipulated and not correct. So they will not ask it also. And they keep on changing, so they don't ask. Now come to the diluent part. The 3 things will have the diluent. BCG have the diluent normal saline. MR have the diluent sterile water or distilled water. And JEE have phosphate buffer solution. So how will you remember it? Very simple. BCG is given at birth. So as soon as the child is born, we want to make the life of child a bit salty. हम बच्चे की जिंदगी नमकीन बनाना चाहते हैं. So to make it salty, we give normal saline. Then M for MR, M for mother love. And mother love is like sterile water, na? So pure. No matter how angry your mother is with you, just press her leg for 10 minutes and she will melt like ice. So sterile water, mother love, MR. And if you write JE, Japanese encephalitis, in the Japanese encephalitis, you can find both J and P. So in JE, what is the diluent? Japanese. So JE have phosphate buffer solution as the diluent. Okay. Now, let's read about tetanus. Because the guideline has changed and PARC has given the recent guidelines. So we should remember it very clearly. In the tetanus, first thing is, no matter which kind of wound it is, if the patient come in 5 years, we will only wash the wound and let the patient go. धो के छोड़ देंगे 5 साल के अंदर. If the history is 5 to 10 years, 5 to 10 years, no matter which type of wound, we will give 1 DT only. Okay. So 5 साल से पहले धो के छोड़ेंगे, 5 से 10 साल 1 DT, 1 DT, 5 to 10 years, any kind of wound. The difference start when they write in the question more than 10 years. if it is more than 10 year and it is a clean wound, but other than clean, they say this line, clean, less than 6 hour patient came, it is non-penetrating and non-lacerating. Okay, so all these is one thing, and other than this, any other wound is known as other wound. So if it is clean wound, history is more than 10 year, we give 1 DT only. But if it is other wound can be dirty, lacerated and all, then here we include tetanus immunoglobulin. So tetanus immunoglobulin is not added in less than 10 year, and tetanus immunoglobulin is added only for other wound. ये दो बात याद रखना, 10 साल से नीचे tetanus immunoglobulin नहीं देंगे, जब more than लिखा होगा तभी देंगे, और other category में ही देंगे tetanus immunoglobulin. Now one more type of patient can come, which can come and tell you that, sir, bhoola, I don't remember the history. So this time you will give full course of DTTT, 5 vaccine, ghapa ghap, ghapa ghap. So now the patient will not forget in her or his whole life. Okay, so full course is only given if patient come with bhoola, forgotten history. And in this case also, only in other wound we will add tetanus immunoglobulin. We will not add tetanus immunoglobulin in case of clean less than 6 hour, non-penetrating, non-lacerating wound. Okay, so I hope you will remember. Now let's do some question which will make me understand whether you understand it or not. Patient come with clean wound. 4 hour back, last TT was given 10 year back. Correct management will be. This is the question of last year NEET, and it was a repeated PYQ. So what will you do here? Clean wound, 4 hour back. Last TT, 10 year back. So the answer will be, can you give me the answer? Drug of choice is a very good, humble guy. You know, he's saying just thank you, very good. You are a good question. Chalo, do ask, do answer this question. What will you give this patient? In this case, it is a clean wound. And do remember, in clean wound which is less than 6 hours, we never add tetanus immunoglobulin. Full course is given only if patient has forgotten. So full course tetanus immunoglobulin is gone. Washing is done if it is less than 5 years. So washing is also gone. Correct answer is DT, which Sweta Singh has correctly replied. Okay. Now, the second thing is that if in the same history, rather than saying clean wound, they would say dirty lacerated wound 10 years back. Even then the answer will be DT. Remember this. In the question, if they gave more than 10 years back, and they say the category of other wound like dirty lacerated and more than 10 years back. In this case, more than 10, then we will add immunoglobulin with tetanus. But if they have not used the word more than 10 years, they just write 10 years. Till 10 years, we give only DT. Whether it's clean or dirty, doesn't matter, only DT till 10 years. Okay. And in the above question also, if it is a clean wound, rather than 10, if I say 16 year or 20 year, even then the answer is same DT. Because in clean wound, anything more than 10 year also will get DT. Okay. And in dirty wound, till 10 year DT, after 10 year, more than 10 year, we will add immunoglobulin with DT. Now, like suppose they have this question, patient came with dirty wound 6 years back, TT taken. So the TT is taken between 5 to 10 years. So it is taken between 5 to 10 years, we will give DT only. So if this is 6 years back or 10 years back, 10 years back also, in case of dirty wound, we will give DT. But if this is 16 years back or 20 years back, and it is a dirty wound, then we will add tetanus immunoglobulin. So remember this, and I hope you will not be wrong. Less than 5 years only wash, 5 to 10 years only DT. More than 10 years, in case of other only, we add immunoglobulin, and we give full course only if history is forgotten. Now let's talk about animal bite or rabies. If they have asked this question recently, that in UPSC exam, patient with scratch and minimum bleeding, minimum, just drops of blood, how will you manage? And dog is fully vaccinated. Now what will you do? This three thing is there. Option A, will you wash and reassure that no problem is there? Option B, will you give rabies vaccine? Option C, will you give rabies vaccine plus human immunoglobulin? Or option D, will you give rabies vaccine प्लस हॉर्स इम्यूनोग्लोबुलिन? मान लो ये मेरा केस है, कुत्ता आया और मेरा बम काट के ले गया आधा, अब मैं चल रहा हूं ऐसे वैसे वैसे वैसे, नहीं आधा बम नहीं काटा, ये वाला केस में क्या है, मिनिमम ब्लीडिंग है, सॉरी आधा काटा बाद में बात करेंगे, हियर इट इज मिनिमम ब्लीडिंग. व्हाट विल यू डू? 3 of the student has answered it A, wash and reassure. My dear friend, this table is directly from Park textbook and they have used the word without bleeding. Also, if there is a scratch or abrasion, we will give rabies vaccine. And if there is some bleeding also, bite with any bleeding, we will go with immunoglobulin also. And do remember, dog is fully vaccinated or not, this is something which we don't consider in India. It is of no consideration, no use. Dog is fully vaccinated or not, we will not consider that. And otherwise, they would be teaching you also dog vaccination schedule. And any owner will say, my dog is vaccinated. Will you trust him or her? No. So dog is fully vaccinated, doesn't matter. There is some bleeding. Answer is C, vaccine plus immunoglobulin. And the dose of human immunoglobulin is 20 international unit per kg. We don't use horse immunoglobulin even in my case because it can cause anaphylactic reaction. The dose of horse immunoglobulin is double, but they only ask human immunoglobulin dose, that is 20. So here there is some bleeding and bleeding will go in category 3. So the answer is option C, correctly answered by Koyal Chatterjee and my lovely student, your drug of choice is his name by which he give the answer. Both are correct. C is the answer. Irfan is saying that, sir, but dog is fully vaccinated. Doesn't matter for India. Okay, because the vaccination in the dog is something which we cannot check whether it is properly done or not. What are the regime? We don't know also. And it can be falsely told by the owner of the dog that it is vaccinated also. So we don't trust on that history. Rabies is 100% lethal. We don't take any chance. If there is without bleeding, then we will give only vaccine. If there is any bleeding, even if there is small drops of blood, we will give immunoglobulin with vaccine. Okay, dear? I hope, Irfan, you will agree. Chalo. Rahul is saying sorry. No, dear Rahul, don't say sorry. Keep doing mistake in the class. There is no wrong in the answer in the class. And in exam, you can be wrong. Here, you should do mistake and give wrong answer because then you will remember it better. So don't be scared of doing mistake. Otherwise, how will you learn? Chalo, now, rabies immunoglobulin is something which we discussed, horse and human. Human is 20, so if you will give it in a 90 kg patient, you will give it 1800. Half dose you will give near bite area if possible, and half dose intramuscular. Now, we have discussed it that if the child return within 1 year, we don't restart, we continue. But there is one thing which INICET asked in this recent exam also, that rotavirus first dose is not given after 15 week if child come. And rotavirus second dose is not given after 6 months. So do remember, rotavirus not given after 6 months. So if a child come after 6 months, no need of giving rotavirus. Okay. So in first year, if child is coming back within 1 year of gap, we will continue with the remaining dose. But let's say child came at an age more than 1 year. So after 1 year of age, we don't give 4 vaccines: BCG, Rota, Penta, FIPV. BCG, Rota, Penta, FIPV not given after 1 year of age. Okay. And when it comes to rabies, we should also know in rabies there are two more regime. One is pre-exposure, which is for veterinary doctor and all, which is on day 0, 7, 21, 28, 3 dose. Because veterinary doctor has also this work to make the dog do sex. And let's say any dog don't like the partner whom they will bite. The veterinary doctor, they are doing a risky job. That's why they took pre-exposure 3 dose 0, 7, 21, 28. And let's say you came back after taking vaccine, and let's say after 1 month second bite occurred. So post-vaccination bite, we take 2 dose 0 and 3. Okay. I hope you know the vaccine regime. One is intradermal, one is intramuscular. They can ask which one is better or preferred. So in intradermal, we give 0.1 ml on both deltoid on 4 visits, 0, 3, 7, 28. So total dose is only 0.8. But in IM, we give 0.15 ml on 5 days, 0, 3, 7, 14 and 28. That's why the total dose in IM is 2.5. So that's why preferred regime is intradermal, because intradermal has less dose, 0.8 ml. That's why in all the government hospital, we get intradermal vaccine. Okay. Now, if they ask this question, the child is 7 kg is coming with 1.5 years of age. We cannot give BCG, we cannot give Rota, we cannot give Penta, we cannot give FIPV, but we can give vitamin A. How much vitamin A will be given? Because the weight is less than 8 kg. Less than 8 kg, so only 1 lakh. Okay. I hope it is clear. Now, total dose of vitamin A which we give is 17 lakh, and for that the total visit is 9 visit. There are something which we mix in the vaccine which they can ask. In the DPT, there is aluminum hydroxide as adjuvant. How will you remember? Very simple. A for aluminum, A for adjuvant. Then in thiomersal, preservative is DPT. How will you remember? If you write the full form of DPT, one full form of DPT is diphtheria pertussis tetanus. Second full form you can make it is DPT have preservative thiomersal. DPT preservative thiomersal. Like that you can remember the full form. DPT have preservative thiomersal. And then MgCl2 is stabilizer in OPV. We put chlorine in water to kill extra bacteria. Similarly, we are putting chlorine of MgCl2 here to stabilize the live virus of OPV. Because out of DPT and OPV, only OPV is live virus. So only in OPV we need to stabilize the virus. That's why only in OPV chlorine is needed. So MgCl2 is stabilizer in OPV, A for aluminum, A for adjuvant in DPT, and DPT itself means DPT have but preservative as thiomersal. Now, sometimes they can create this clinical question that a child with nephrotic syndrome is on steroid. That means it's an immunocompromised child. Which of the following vaccine will not be given? So whether it's an immunocompromised child or pregnant female, all live vaccine are contraindicated, but except yellow fever, which I think you all know. Yellow fever vaccine is one live vaccine which can be given even in pregnancy. And when we give yellow fever vaccine, it gives a lifelong protection to the patient. Protection starts from 10 days to lifelong. So, to answer such question, which vaccine we will not give in an immunocompromised child or nephrotic syndrome child on steroid, we have to remember all the 11 live vaccine. And to remember 11 live vaccine, the simple thing is, if this 5 vaccine, cholera, plague, polio, influenza, JE, these are both live and killed. So if you remember these 5, you can tell easily majority of live and killed. And these 5 can be remembered by the mnemonic CP pe aijo. Come to CP. CP stand for Connaught Place in Delhi and Center Point in Aligarh Muslim University. I did my MBBS from AMU, MD from AIMS New Delhi. So in both places there were CP. And if a girl is saying come to CP or boy is saying come to CP, it means there is chance that some good dinner, love making can be there. So CP pe aijo is the mnemonic to remember this 5. C for cholera, P for plague, P for polio, I for influenza, J for JE. CP pe aijo, cholera, plague, polio, influenza, JE, these have both live and killed straight. Other than that, it's not BMW, it's BMV. B for BCG, M for MR, V for varicella. Varicella have Okka strain, there was a song also. Savila Villa, Savila Villa. It's time to Africa, Wakka, Wakka, Ayo. So that's the strain, varicella, Okka strain. And BMV, not BMW, Y. And now, because why for yellow fever, we already read yellow fever is live, but it still can be given to mother. And of course, we all know that all which is oral vaccine are live. So rotavirus, typhoral, both are also live. Okay, so BMB and then rotavirus, typhoral. We will read BMVY, rotavirus, typhoral. These are 6 things, and the 5 are CPP, IJO. So total 11 vaccine are contraindicated in immunocompromised state. Now, if it is, they ask which is a killed vaccine. So 5 we already remember, CPP, IJO. Only 2 you have to remember, hepatitis A and rabies are killed vaccine. Then in protein vaccine, very simple to remember, P for protein, P for pertussis. Pertussis is protein vaccine. Other than that, there is anthrax and Novavax, but they only ask pertussis, which is protein. When it comes to toxoid vaccine, toxoid is 2 things, diphtheria, tetanus, and you will be surprised to know, in INICT they have asked, diphtheria is which type of vaccine? Toxoid. Cell wall vaccine, polysaccharide vaccine, one is Hib. We said na, Haemophilus influenza type B. This is also a polysaccharide vaccine. Other than this, there is pneumococcal, meningococcal, and VI polysaccharide, 3 things. So, in surgery also, they can create a clinical question that there is a patient who went through splenectomy. Which vaccine will you give? So in a post-splenectomy patient, of course, antibody will be less, immunity will be low, and this patient can die from pneumonia. So in post-splenectomy or old age or HIV patient, which vaccine is given? Pneumococcal, to prevent from pneumonia. Do remember. Meningococcal, they ask which subunit is not there. So in meningococcal vaccine, we have ACYW135. So which is not there? B subunit is not there. They will give ABCY, which is not there. People think Y is not, but answer is B subunit, beta subunit is not there. Then there is VI polysaccharide for typhoid. And this typhoid VI polysaccharide we give at 2 year, 5 year, and 8 year. 3 doses is given, 2 year, 5 year, 8 year. Okay. Now, recombinant vaccine is only one. BSAG, surface antigen is there, plus DNA. So hepatitis B is the only recombinant vaccine. Okay. Now they ask a lot of questions from open vial policy in last 3 years. They will ask which vaccine will you keep after opening till next 1 month, which vaccine will you throw. So very easy to remember. You just have to say it with me and you will remember. Hep B, PCV, or tetanus, or polio. These 4 vaccine category, they have to be kept even after opening for next 1 month. You can use them. What are those? Hep B, PCV, or tetanus, or polio. Because Hep B, PCV is there. All tetanus include DT, TT, DPT, Penta. DT, TT, DPT, Penta are in tetanus, very easy. And in polio, there is OPV and IPV. OPV is live, so live in. Live is Sabin. And IPV is killed. So it is killed due to shock. Shock laga mar gaya. Shock strain is IPV and live is Sabin. Live is Sabin, IPV is killed. So can you remember these 4? Hep B, PCV, all tetanus, all polio. Now some teacher teach that rotavirus also follow open vial policy. But PARC 27th edition, the recent one, has given a diagram with the image of the vial, and they have written it clearly that rotavirus, MMR, they don't follow open vial policy. And it is from PARC line. I am not, do not trust expert like me, trust evidence. And the evidence we have to follow here is the PARC recent edition. So rotavirus, MMR, etc., some other vaccine also don't follow open vial policy. Okay. So from here they can ask this question that in a vaccination camp, MR and pentavalent are open but not used. In next camp, 2 weeks after this, what will you do? Will you throw both? Will you use both? Will you use MR, throw penta, or will you use penta, throw MR? So please try to reply the answer. Meenakshi Haridas is saying Hep B, PCV, or tetanus, or polio. She will never forget. Thank you so much. Rahul is saying, sir, आपको rabies नहीं होने दूंगा. Rahul will protect my bum from being taken by dog. Rahul will put his hand on dog mouth and beat him, bite and hit him and prevent me from bite. Very good. What a love, Rahul. Very good. So now tell me this answer. What will you throw? What will you use? So remember, Hep B, PCV or tetanus or polio, this we will keep and we will throw MR. So we will throw MR and we will throw MR and we will use Penta. So correct answer is option B. Okay. So now, very good. Sri Harsita has correctly replied. It use Penta through MR. So we have done with vaccination mostly, but we can read the cold chain very quickly. First thing we start with cold chain is the walk-in cold room, walk-in deep freezer, which is at state or district level, which prepare ice pack. Then from this walk-in cold room, walk-in deep freezer, the vaccine goes to ILR. From the ILR, and in the ILR there is a dial thermometer, special type of thermometer. ILR is same as the ice cream keeping machine in most of the shops we have now. That is ILR, mostly like that only. So we cannot take ILR to the village for vaccination. So we will carry it in vaccine carrier or day carrier. Now day carrier has two ice pack. So if you will look from above, it will look rectangular like this. Vaccine carrier has 4 ice pack. So if you will look from above, it will look square shape. And do you remember, they asked this question that what is the maximum vaccine which you can carry in vaccine carrier or day carrier? So each ice pack can carry maximum 5 ampule. Vaccine carrier has 4 ice pack. So maximum can be carried is 20 ampule. Okay. And day carrier can carry maximum 10 ampule. Average they can carry 3 to 4 ampule. So day carrier will average carry 6 to 8 and vaccine carrier will average carry 12 to 16. But they usually ask maximum only. Do remember maximum is 20 in day vaccine carrier and 10 in day carrier. Image also I hope you will identify. Now we have to put the vaccine in the ice pack while giving it. Otherwise this cold chain of 2 to 8 degrees Celsius can be broken. But tell me one thing, when you received COVID vaccine, did you receive it from ice pack or did you receive it from table like me? I'm sure 99% of you, if you remember, you have received it from table only. So what is the problem? If you give it from table, it means the cold chain of 2 to 8 degrees Celsius can be broken. And if it is broken, then we can check it by the vaccine while monitor whether the vaccine can be used till now or not. In the VVM, if the color is same, we will don't use it, we will discard it. And if the color is dark inside as compared to outside, then we will definitely throw it. If the inner square is light or lighter or light, then we will use it, same color, discard it. But the problem is in the COVID vaccine, there was no vaccine while monitor. And you must be thinking that, okay, we took it from table, but how come a PSM teacher took it from table? Was he busy somewhere else, not looking at the vaccination thing? No. Actually, in COVID, they did a special thing. They opened the vial only when 10 people has accumulated. So the vial was open only for 5 minutes maximum. And it's okay to break the chain for 5 minutes. So in COVID, it was allowed. It was not a problem. Now, one question they have asked from corona vaccine is, what is the most common side effect which can occur with COVID vaccine? So most common side effect is thromboembolism. And recently you must have heard it in newspaper and other thing also that Covishield company, AstraZeneca, they have accepted that Covishield or AstraZeneca can cause thromboembolism, which lead to some heart attack death also during COVID vaccination. So this is the most common side effect. We already read the route of vaccines earlier. Now vaccination chapter is also finished. And now we can go to read the next chapter, environment. Okay. So in the environment, there is 2 fraction, air, sound, light, and air, sound and light are the 3 different fraction which is there. And then water is the other part. So let's first read air, sound, light. Very simple and easy. In air, they will ask which three of the gases are best indicator of air pollution. So remember, SO2 is the best chemical indicator. Then if there is a smoke particle, it will deposit on a special kind of cloth and it will make the cloth dirty. So the cloth is dirty, that's why they call it soiling index. Soiling index do not measure soil pollution. It only measures smoke concentration in the air. It only measures air pollution. So SO2 is smoke and particulate matter. These three are best indicator if given together. Because SO2 is best chemical indicator, smoke is there in soiling index, and particulate matter we use in air quality index. And you must have been listening it in the newspapers and other places also, that if the air quality index, let's say last study only it was 61 in Safdarjung and Ames area. So if it is 61, it is Satiswa ka factory, Satish factory quality. If it is less than 50, it is good. 51 to 100 is satisfactory. So till 100, it's okay. After 100, you can remember the mnemonic MPVS, moderate, poor, very poor, severe for every 100. So if they say 468, 478, all are more than 400, they all are severe. Okay, so remember MPVS, moderate, poor, very poor, severe. For every 100 to 200 moderate, 200 to 300 is poor, 300 to 400 very poor, and then severe. Greenhouse gas effect, what is the most common greenhouse gas? Water vapor. In PARC it is written, and then there are 5 other gases: CO2, methane, nitrous oxide, which is used for surgery in children, and they gave the laughing gas, the child laugh, hey, and they operate during that time. And then there is chlorofluorocarbon and ozone. These all are greenhouse gas, which is causing the global warming in India and the world. So the leader of the world, they say that let's meet together in Kyoto, let's have free alcohol together, and we will throw big things. We will call it Kyoto Protocol, which is for decreasing greenhouse gas emission. And then they liked the party so much that they had it again in Montreal, call it Montreal Protocol, which is to decrease chlorofluorocarbon production so that we can protect the ozone layer. So how will you remember it? I used to remember it like this: Q chodi hari gas. Why you emit green gas? Because Kyoto start with Q, and Q in Hindi it means why. So why you emit green gas? Green gas is for Kyoto. Montreal is to protect ozone layer. Okay. Anyway, who emit green gas? I think who was that? Who fight Hulk? Hulk might be emitting green gas. Nah? So do remember Kyoto for green gas, Montreal for chlorofluorocarbon production reduction. Then there are 2 types of air pollutant. Primary is those who are formed without mixing with other gas, like volatile organic compound, which are formed without mixing. It is big name, but it's still primary. And ozone, see, it is such a small name, but ozone is formed by O2 and O free radical. So if you are formed by mixing, you are secondary air pollutant. Without mixing, primary. Like volatile organic compound, primary. And other than this air thing, they also ask questions from the instrument of air. Instrument is, if it is Carta thermometer. Carta thermometer has measured 2 things: air quality, air velocity, and cooling power. एक इस पे शेर याद आता है कि खुली हवा के दिए कब के बुझ गए होते, कोई तो है जो हवाओं के पर उतरता है ना. So this someone is cutting the air, and the air velocity and cooling power of air both are being measured by Carta thermometer. And we all know Carta is long, like Carta laga, it's always long. So if it is Carta thermometer, they will give a long type of thing. But if it is a globe thermometer, globe is circular or oval. So globe will be like this. Carta will be like long. So do remember, Carta thermometer measure air velocity, cooling power, but globe thermometer, because it is circular oval, it will absorb the radiation of the whole room and it will measure radiation temperature. Okay. Now the third instrument is Assman psychrometer. Doesn't it look like it will go in someone ass, and Assman psychrometer? It looks like a proctoscope anyway. So wherever they will use the word psychro means humidity. So if psychro is given, it will measure humidity only. And if you look at my name also, it is Ashwini, Assman psychrometer, measure radiation temperature. Psychrometer measure humidity, radiation temperature measured by globe thermometer. Now the second psychrometer is sling psychrometer. They can give you the image based question here, and they will ask which instrument is this. So remember this image of instrument is a very important topic nowadays. And why they call it sling? Because when you hold it from this blue handle, it will rotate in the room like this, up, down, up, down, up, down, like a sling. And in the sling psychrometer, there is two type of thermometer, wet bulb, dry bulb. So they ask it in our time, what does wet bulb, dry bulb thermometer measure? They are in sling psychrometer, so they will not measure temperature. They will also measure air humidity. Okay. So do remember all these four instruments. Now, when it comes to sound, in the sound, they can ask you only two things. One thing, what is the safe limit of sound in hospital? That is 20 to 35 decibel. Second thing they can ask is, at what chronic exposure of sound there is permanent loss of hearing? So it is 95 to 100, which is leading to permanent loss of hearing. And at what sound limit there is rupture of tympanic membrane? 165 decibel. Okay, so these three things they can ask. Hospital 20 35, 100 permanent loss, 165 फट जाएंगे पर्दे कहां के? कान के. Okay, so rupture of tympanic membrane 165, permanent loss 100, and hospital 20 to 35. Then green belt is something where they are planting tree on both sides to decrease sound pollution. But green corridor is when you have separate lane for rapid transit of ambulance to promote organ donation. And organ donation maximum occurring is in Tamil Nadu. They can also ask you about head-on matrix. What is head-on matrix? It is a 3x3 table, 3x3 table. Purpose of this 3x3 table is to decrease accident and for accident prevention. We want to know what is the cause of accident before the accident, what are the factors like sleep deprivation, alcohol or something, during accident, and after accident, how we took the patient to hospital and all. So this is in the 1-3 side. Then above 3 side we write the reason in the driver, the reason in the road, the reason in the hospital which caused the death and all. So head-on matrix is 3x3 table for accident prevention. Second thing they can ask is the SI unit of brightness, because light candle gives the brightness, so candela is the SI unit of brightness. Then they can ask illuminance, what is the SI unit? Lux. And luminance, what is the SI unit? Lambert. So how will you remember these three things separately? See, you might have seen the Lux ad. In that Lux ad, Kareena Kapoor and Katrina Kaif, Karisma Kapoor, they all bath in the same tub with Lux. And they say, this is the reason for my glowing skin. And when they tell it all lie, they even don't wash their potty hand with it, but they say Lux is the reason for my glowing skin. And in one of that ads, they also put Shahrukh Khan in that tub. So to remember it, you can remember that in that Lux ad, they are doing Ilu Ilu, I love you, I love you. So Lux ad, Lux, Ilu, Ilu Ilu. Okay. Then to remember this luminance, you can remember Lamba, lamb. What is lamb? Bhed ka bachcha, hai na? Sip child is lamb. So imagine there is a big lamp. Lamba lamp, Ilu Ilu in Lux. So I love you in Lux. Illuminance Lux. And candle is giving brightness. So candela for brightness. You can remember these three separately, I hope. Okay. Now, next is what should be the thickness of lead apron to protect your tetanus or testicle? It should be 0.5 mm, not 0.5 centimeter. And radiation exposure should be 5 radon per second. Okay. It should be 5 radon per second, which is safe radiation exposure. Daytime illumination factor simply means as compared to outside light, how much is entering inside. And of course, kitchen need more light, 10% as compared to drawing room. So daytime illumination is 10% for kitchen, 8% for drawing room. Now let's come to water. When it comes to water, I was teaching in between about this STD kit. If they say female with vaginal discharge, cervical erosion, then we will give which category? Gray. Because cervical erosion means cervicitis and it is treated in gray. And if there is cervical infection, discharge will come through vagina only. So patient will report vaginal discharge, but actually it is gray category because it is cervical infection. Okay. Let's talk about water. Water, they say, had 4 qualities: safe water, wholesome water, handsome water, which can be remembered by PCOD. P means free from pathological agent. Color should be less than 15 TCU. There should be no odor. and safe for domestic purpose means turbidity should be 0. Remember these two things, turbidity 0, color less than 15 true color unit. So how much E. coli you can accept in 100 ml drinking water? Answer is 0. Because if there is one E. coli comes from human intestine. Even if there is one E. coli, it means you are drinking 30, sick. So you cannot drink it. That's why it should be 0, no pathological agent. Color 15, turbidity 0. When they say sanitary well, it should be covered from above, but main question they ask is, it should be 15 meter or 50 feet away from some pond or some source of contamination. And it should be 6 meter deep cemented so that water cannot come from upper layers, should come from lower. 6 meter deep, 15 meter cemented. Similarly, we will also talk about septic tank. They have asked it, what is the depth of septic tank? It is around 1.2 to 1.5 meter deep. So septic tank is 1.5 meter deep. Sanitary well is 6 meter deep. Okay, 1.5 so septic tank. Now let's read about fluorine. They ask it in recent exam that when will you have this? When will you have the osteofluorosis? When will you have a brittle, not the brittle bone? They use the different word, deformity in the bone. Which concentration of fluorine lead to deformity in the bone? So the fluorine concentration more than 10 lead to deformity, and it should be more than 10, which lead to not brittle bone but a special type of condition which I am missing, deformities in the bone. So it should be more than 10. Dental fluorosis can occur if the fluorine is between 3 to 4. Then dental fluorosis can occur. And they can give you an image based question of dental fluorosis with white plaque on teeth. That is dental fluorosis. So remember, they have asked in one exam, what is the normal concentration of fluorine in water? 0.5 to 0.8. And it's very easy to remember because chlorine is also almost same, 0.5 to 0.7. So 0.5, 0.8 fluorine, 0.5, 0.7 chlorine. So if they ask how much chlorine should be left in the water all the time, what is the minimum amount of chlorine in the water? That is known as residual chlorine, and residual chlorine should be 0.5. Okay, do remember 0.5, 0.7 chlorine, 0.5, 0.8 fluorine. So if the fluorine is less than 0.5, dental caries will occur, दांत सड़ जाएंगे. But if the fluorine is around 3-4, dental fluorosis, white plaque deposition, more than 10, brittle bone will occur. How can you remove the extra fluorine? By Nalgonda technique, in which we add lime, then allium, then bleaching powder. That's why the mnemonic is lab. Lime, and then we add allium, then we add bleaching powder. Now, we discussed chlorine in drinking water, 0.5, 0.7. But in swimming pool, you know, some people do hanky-panky. So there we need more chlorine, around 1. And of course, during flood also, some people are so opportunist, mauka first, they do sit in flowing water and wash their bum in the same water, है ना, उसी पानी में, है ना, करते हैं और धो भी लेते हैं एक ही बार में. So in flood also we need to keep a higher concentration of chlorine, 0.8. Mainly they ask question from chlorination, and in India chlorination is done by bleaching powder which contain 33% free chlorine. So if there is 100 gram of newly prepared bleaching powder, it will have 33 gram of protein. 33 gram of chlorine. Now, how do they chlorination in India? I was working for 3 months in tribal areas of Chhattisgarh, and they took me to a well to teach me chlorination because I was not aware how to do chlorination. I used to think this is the work of someone who is supplying water. Why we are reading about it? So they took me to the well, not to throw me into it, है ना, कि मर जा मोटे किस काम का, but to teach me chlorination. And they did it in 3 simple steps. First thing they did was they took some amount of chlorine water from the pond, put it in 6 different white colored tubes, and all these white tubes has a blue color indicator, starch iodine in it. So this apparatus is known as Horrocks apparatus. And what is Horrocks apparatus telling us? It is telling us that how much bleaching powder we will put which will kill all the bacteria. कितना bleaching powder डालेंगे कि सारा बैक्टीरिया मर जाएगा. एक तरीके से ये कह रहा है कि कितना क्लोरीन पानी डिमांड कर रहा है सारे बैक्टीरिया को मारने के लिए. Horrocks apparatus telling us that how much chlorine water is demanding to kill all the bacteria. How much bleaching powder is needed to kill all the bacteria. So that's why Horrocks apparatus tell us chlorine demand. What is chlorine demand? Amount of bleaching powder or chlorine needed to kill all bacteria of water. Okay. And remember the indicator of Horrocks apparatus. What was the indicator? Starch iodine was the indicator. Blue color indicator was starch iodine. Now, they put it in the water. I said, now work is done. Let's go to have food. They said, no, wait for 1 hour. In this 1 hour, bleaching powder will release some iron. They will do dishum and kill the bacteria of the water. So this 1 hour, remember this was also a question of recent exam. 1 hour is the contact period. Contact period. In this period, bleaching powder will release some iron and they will kill bacteria. So contact period is 1 hour. And which iron is the most important iron of bleaching powder killing most of the bacteria? Answer is hypochlorous iron. कैसे याद रखोगे? देखो, the one which has rus. Rus is also a Hindi word which means juice. So the one which has rus or juice in it will kill maximum bacteria. The one with one sword will kill maximum bacteria. HOCl minus will kill maximum bacteria. HOCl2 and chlorine will not kill that much bacteria. HOCl will kill around 80-85% bacteria. So after 1 year of action by HOCl minus ion, I said, now the work is done, let's go to have food. He said, no, wait. We still have to take the sample of water and check how much chlorine is left in the water, how much is residual chlorine. Because if residual chlorine is less than 0.5, it means chlorination has not done well. Let's do it again. So we have to check residual chlorine. How we check residual chlorine? By the instrument known as chloroscope. And what is the residual chlorine? Residual chlorine should be less than 0.5. Remember this 2-point thing. And in the chloroscope, they do two type of tests, orthotoluidine or orthotoluidine arsenide. Now, they have asked in one of the exam that does orthotoluidine detect free chlorine or combined chlorine or both? So remember, whether it's orthotoluidine or it's orthotoluidine arsenide, they both detect both free and combined chlorine. So then you can ask, sir, what is the difference between them? The difference is in orthotoluidine test, the reagent orthotoluidine changes color so quickly that we are unable to tell free and combined, we tell it together. But in orthotoluidine arsenide, reagent changes color slowly. So we can separately tell how much is free, how much is combined. Okay, and why we want to know combined? Because combined chlorine is HOCl minus. So if we know how much is combined chlorine, we can know how much killing power is left in the water. Okay, so both detect both free combined. Orthotoluidine detect it together, orthotoluidine arsenide detect it separately, and orthotoluidine arsenide is also not affected by nitrite and other ion impurities. So which one is better? Of course, the better one is orthotoluidine arsenide test will be better. Okay. Now, after this, they can ask some question about sewage, sewage and all. Sulage is the kitchen wastewater. Sewage is those wastewater with potty in it with fecal matter. So sewage is the dirty water about which we have to read. So they have asked this question that if there is a camp of 10,000 soldiers, how much area of land we should dig for deep trench latrine? What we prepare, what is the preferred thing? Deep trench latrine, how much area we should dig? So the area we should dig is 1 acre. We should dig for 10,000 people. And which latrine is preferred in camp? Deep trench is preferred in camp. Okay. Now, they also can ask question from septic tank. In 2 of the recent exam, the question has been asked from septic tank. So let's read about septic tank and all. In the septic tank, one thing is that in the main tank, there are 2 chambers in which anaerobic digestion occur. And after anaerobic digestion, as I said you earlier, the depth of the septic tank is 1.5 meter. In this 1.5 meter, above 30 centimeter is the air space. So when anaerobic digestion occur, air come with all spores and all, and it will accumulate in the above part. So then from this above part, a pipe goes out and it goes in the subsoil. Subsoil means that soil area which is nearby to septic tank. We take a pipe from this and put it in the subsoil. This subsoil is known as aeration chamber also. And here in this aeration chamber or subsoil, aerobic digestion of waste occur. Because now we can get the air here. So aerobic digestion of waste occur here. And this subsoil or aeration chamber is the most important part of septic tank. You can call it as the heart of septic tank, aeration chamber. They can also ask you which is the heart of active sludge method. So in septic tank, the decomposition occur by active sludge method. And again, if they ask the most important part, again and again you have to answer aeration chamber is the most important part. Okay. So do you remember this part? One more thing you can remember is whether the fecal contamination is fresh or remote past, how will you detect it? So if it is fresh, these three things, E. coli, streptococci and clostridium can be found. And E. coli can be detected by presumptive coliform test, which is done by multiple tube method, or the confirmatory test is Iskman test. So these two ways we can detect E. coli. Right? Most commonly we use is multiple tube method, and this multiple tube method is presumptive coliform count. It is a screening test. Confirmatory test is Iskman. So E. coli, streptococci, clostridium, all three are found in fresh potty. Abhi garma garam jo hua hai na, fresh one will have all three. But out of these three, only clostridium is capsulated bacteria. So only clostridium can survive for 10-15 days. So remote past fecal contamination, only clostridium will be there. Okay. So these are the things which we have to remember in water part of the environment. We have done the revision of nutrition, biomedical waste, vaccination and environment. Now we can revise epidemiological concepts. Then we can go to read the epidemiology and biostats. One concept which I definitely want to revise is about global hunger index. They can ask which is not included in global hunger index. Global hunger index do not include infant mortality rate, is not a criteria of global hunger index. IMR is also not a criteria of sustainable development goal. Third goal is for health, which do not have IMR. We will talk about it. Anyway, we can talk it here also. SDG have three criteria. They mostly ask about maternal mortality ratio, which is 70. Then there is neonatal mortality rate, which is less than 12 per 1,000. And 70 is per lakh, of course. Maternal mortality ratio is per lakh. And under 5 mortality rate, they can say the criteria is 25 per 1,000. So 70, 12, 25, 70, 12, 25 are the three target in SDG. Again, in SDG also, IMR is not a criteria. How will you remember it? Very simple. Under 5, 25, 5 into 5, 25. MMR 70, and half of 25 is 12, approximately 12. So under 5, half 12 is neonatal mortality. Now, in global hunger index, what are the criteria they can ask? IMR is not a criteria. The criteria is under 5 mortality, undernourished children, stunted children, and wasted children. And in recent INICET and a lot of exam, they ask this question again and again, that if a child is low weight for age, is it acute or chronic or both? So imagine me as a malnourished child, very malnourished. So I can be malnourished because I have loose motion for last 1 month. Acute reason can be there. Or I can be malnourished because my mother has not given me food since I was a kid. So that is chronic reason. So both acute and chronic, both can lead to low weight for age. Do remember, acute, chronic, both either together or any one of it can cause low weight for age. Second question they ask is low weight for height. Low weight for height means height is good, but according to the height, weight is not there. So it can occur if the child is having acute malnutrition. Let's see, low weight for height means the child is eating good since childhood. So there is no chronic malnutrition. Weight is low because of last 1 month he is, let's say, having diarrhea or breakup and not eating. So low weight for height is acute. Do remember, people when they see height, they directly tick chronic. No, if there is weight and height both, it is acute. If it is height for age, height has not grown, it means there is chronic problem, stunting is there, that is there. And if there is weight for age low indicate both acute and chronic together or separately. That's why we use the word and or, any one or both of it. So do remember that in global hunger index, the four things are under 5, undernourished means low weight for age, stunted and wasted. 4 criteria are there. Okay. And do not forget to revise SAM. They ask it again and again. SAM have weight for height less than minus 3 standard deviation. Why? Because if weight for height is low, only then it is acute malnutrition. So acute is low weight for height. If let's say weight for height is minus 1.73 Z, this was INICET question. If weight for height is minus 1.73 Z, it means there is no acute malnutrition. Because acute malnutrition occur only if weight for height is less than minus 2 standard deviation. So if it is minus 1.73, acute malnutrition is gone. This child can have chronic malnutrition, but he cannot have acute malnutrition. For acute malnutrition, weight for height should be, if it is severe acute malnutrition, then it should be less than minus 3. And if it is moderate malnutrition, then it should be 50 percentile to minus 2. I hope you all know this growth chart thing. In the growth chart, they can ask what is this between second and third line. So between second and third, it's not mild, it's moderate malnutrition, and moderate malnutrition is below minus 2Z. So if the child is minus 1.73, he is in this part which is between 50 percentile for boy weight and between third percentile for girl weight, because girls have less weight than boy. Third percentile for girl. So sometimes they ask, what is the cutoff for normal? Normal are those children whose weight for age or weight for height is coming in this range between 50 percentile and third percentile for girl. They are said that they are following road to health. Okay. So if it is moderate malnutrition, it is between minus 2 to minus 3. And if it is less than minus 3, then it is severe malnutrition. Okay. So severe acute malnutrition must have less than minus 3 weight for height, mid-arm circumference less than 11.5. That has also been asked. And there should be visible wasting or edema. Okay. Do remember the 3 criteria for SAM. And in Anganwadi, the growth chart which we draw is weight for age in Anganwadi. Second question they can ask is, up to which age children come to Anganwadi? 3 year, 4 year, 5 year, 6 year. Answer is up to 6 year children come to Anganwadi. Not 5, because in a rural area, usually after 6 they go to first class and all. So it's there. Okay. So Minakshi Haridas is correct in answering the previous question. And in fluorine, if it is more than 10, Tejas is saying it will lead to osteogenesis imperfecta. So if it is osteogenesis imperfecta, fluoride will be more than 10, brittle bone or osteogenesis imperfecta. Chalo, now let's discuss this concept of PQLI HDI, which we commonly miss, but very important. So PQLI is 4-letter big, so the range is also big, 0 to 100. HDI is small, 0 to 1, so the range is also small, 0 to 1. Main thing, the way to remember is PQLI can be remembered as PQL1. So the life expectancy at 1 year is in PQLI, L1. And HDI is life expectancy at birth. Now, PQLI is for poor country, HDI is for highly developed. It can be used for any country, but HDI is for better for highly developed, HD for highly developed, P for poor. And in which country will you measure literacy rate? Poor or highly developed? You will measure it in India or UK? You will measure it in India. Poor country, you will measure literacy rate. So P for poor, literacy rate, poor country. Because in UK, even the child is speaking English, bacha English bol raha hai. So in UK and other, we use mean year of schooling. Okay, HDI, mean year. Now, per capita income do not matter for India, because in India, only 2% population has 90% wealth of India. If you remove that 2%, our per capita income will go dhoosh below the ground. So per capita income is for highly developed country like Russia and all. For India, we measure infant mortality rate. And this was the NEET question, that which is the best indicator of accessibility and affordability of healthcare system? That is IMR. Because if infants are dying more, it means hospital are not nearby, not accessible, and hospital are not free, not affordable. So do remember, accessibility, affordability by IMR. Second thing, whether ASA is working or not, that also detected by IMR. Third thing, whether female health condition is good or not, that is also best detected by IMR. Because why does infant die? The most common reason of IMR in India is premature delivery. Premature delivery means delivery before 37 week. So if child are born premature, it means mother health is not good. So female health condition is also reflected by IMR. Okay. Chalo. So do remember, IMR is 3 indicator. PQLI have L1, life expectancy at 1 year, literacy rate, and IMR. Chalo. Now, they can give you question on case fatality rate. It's very simple to remember case fatality rate. It is telling us killing power. In the case fatality rate, we write case below, fatality above. So let's say in the village, 5 died due to TB out of total 200 TB case. So we will write the death due to TB above 5 and total TB case, which is 200, I am writing below. And then if you solve it, 5 by 200 into 100, it will be 5 by 2 or 2.5. So do remember, case fatality rate has case in denominator, fatality as numerator. And what is case fatality rate tell us? It is telling us killing power. Like for rabies, case fatality rate is 100%. That means out of 100 people who will become case of rabies, all 100 will die. So that is the meaning of case fatality rate. Then there are two more things, proportional and specific mortality. They all have the same numerator, number of death due to specific disease. In proportional mortality, the denominator is total death, not total case. And in specific mortality, the denominator is total population. So case, proportional, specific are the three things. Denominator are case, death, population. And when it is population, we multiply by 1000, otherwise we multiply by 100 only. So these are the three formula, but mostly numerical come from case fatality. That is the more important thing. Case fatality rate tell us killing power. Proportional mortality rate tell us that which disease has highest burden out of total death. Like for example, WHO write that in India, 58% people die due to cardiovascular disease. So total death, if it is occurring 100, out of 100, 58 is due to cardiovascular disease. That means cardiovascular disease is having high burden out of total death. So burden of disease out of total death, that is proportional mortality. And specific will tell us which population is at high risk to die. Like TB patient population is at high risk to die. So specific mortality rate tell us high risk population. Proportional tell us the burden of disease out of total death, and case fatality rate tell us the killing power or virulence, which is maximum for rabies 100%. I hope these three you can remember separately. Now let's discuss these two questions which they keep asking, direct and indirect standardization. When do we do it? What is the purpose of doing it? And how we do it. So let's say you are in class 4th and are wearing half pant only, and you had a fight with class 12th student. Let's say it's Meenakshi who is in class 4th, fight with class 12th student. Meenakshi will fight directly with that class 12th student? No. If she will ask for other friend to come and then fight indirectly. So whenever we are comparing death of a small population with large population, we use indirect standardization. Like let's say Dr. Meenakshi want to get fund for street children. So first she will call all the hospital of, let's say, her state. Suppose she is, I don't know her residence, but suppose she is from, let's say, Jaipur. So she will call all the hospital of, she is from Rajasthan, suppose. So she will call all the hospital of Jaipur and she will calculate observed death by calling them, because she is doing the research, she is observing it. And suppose she found there is 30 death out of 1000 street children. So this is a small population, non-standardized population of street children. Now she had to compare it with national big population, expected population. So she will compare her observed death with expected death of India, which is 3 per 1,000 in this age group 10 to 15 year. So observed death which she found was 30 per 1,000. Expected death for India is 3 per 1,000. When she will compare it, 30 by 3 will come 10 and standardized mortality rate will come 1,000. So then Meenakshi can go to the Chief Minister of Rajasthan, which is Mr. Bhajan Lal, and he can say, hey Bhajanwa, give me some fund so that I can prevent death in street children, because in them the death is 10 times more than expected. If she will say 10 times more, she will might not get fund. So then she will say the standardized mortality rate in street children is 1,000 as compared to expected death. Okay, so then she might get the fund. So do remember 3 points about indirect standardization. First point, in indirect standardization, we compare a small non-standardized population with a large standardized population. Second thing, the formula of SMR is observed death by expected death. And in recent MCI exam, they gave you a numerical on that also. They said that the expected death is only 2, observed death is 12. How much is the SMR? So SMR is 6 or 600. SMR is 600. 12 by 2 you will get 6 and multiply by 100, 600. So this is the second thing. Third thing they can ask is, what is the best mortality indicator? That is standardized mortality rate, because we can use it even if we don't know the age specific death rate. Even then we can use SMR, so it's the best mortality indicator. Now, if a small population observed death compared with expected, we do indirect. But let's say Dr. Meenakshi is in class 12th and she had a fight with class 12th student. So now she can fight directly. The same is the case with direct standardization. We do direct standardization when there is too large standardized population and we want to compare their age specific mortality rate. When we want to compare the age specific mortality rate of, let's say, Japan with India, too large population, we cannot use crude death rate, because crude death rate of India is only 7, crude death rate of Japan is 11, because they have more old age, so the crude death rate is more there. So we cannot compare crude death rate. What we can do is we can compare age specific death rate of 0 to 60 year Indian with age specific death rate of 0 to 60 year Japanese. So in that case, we are comparing the age specific death rate mortality rate of too large population. Then we will get the correct idea that India need to learn from Japan, because India has it more age specific mortality rate. So direct is when too large is compared, and we are using a direct standardization to compare age specific mortality rate, okay, of too large standardized population. I hope you will remember it. Now, one more thing they can ask is, from this crude death rate, birth rate, they can give that crude death rate, like for say India is 7 and crude birth rate is 20. Find growth rate. Death rate, birth rate they will give. They will say find growth rate. It was a question in recent FMG exam also. Find growth rate. Option A, will it be 13? Option B, will it be 1.3? Option C, will it be 140? Option D, will it be 20 by 7? How will you find it? What is the answer? Please reply. I am waiting for your reply. Find the growth rate. If birth rate is 20 and death rate is 7. And do remember the definition of death rate also. It is total death by mid-year population multiplied by 1,000. When do we measure mid-year population? On 1st of July. Because till June 7 month, after July, till June 6 month, after July 6 month. So we measured on 1st of July. What is the answer here? Rakesh Kumar Tiwari is saying B is the answer. That means 1.3, and Rakesh Kumar Tiwari is absolutely right. In growth rate means जो पैदा हुए minus जो मर गए, है ना, birth rate minus death rate. But when we find growth rate, we also divide it by 10. Why? Because growth rate is in 100%, but we can see birth rate, death rate is in 1,000. So to remove the extra 0, we divide it with 10. So this is the formula of growth rate. They can ask a small numerical on this formula in your NEET 2024 also. Answer will be 1.3, not 13. Okay. Yes, Meenakshi is also correct. Chalo. So we read about mortality measurement. Let's revise morbidity measurement because we confuse in this area, we miss this area, so revise it. In morbidity indicator, best indicator is DALY. And in NEET 2023, they have asked this question that year of life lost due to premature death. What is this known as? This is known as potential year of life lost. Let's say in India, we are expecting that death will occur at 70 years, and suppose an Indian died at 62 years. So how many years early that person died? 70 minus 62, he died 8 years early than expected. This is potential year of life lost, PYLL. Now, this is potential year of life lost, and when we calculate DALY, then we add two things in DALY. DALY means potential year of life lost, first thing. Second thing, year of life lived with disability. यानी कितना साल खटिया पे पड़ा रहा, सफर करता रहा, प्लस कितना साल पहले टपक गया. How many year lost plus how many year you were suffering. Both add, then it will become DALY, and DALY is best mortality indicator. If you want to get fund for mental health patient, hemiparesis patient, then you can only represent burden in DALY, okay, which is 2 component. So let's say an Indian died at 62 years, and last 10 years this Indian is living with hemiparesis. What will be the DALY? So he died at 62. Expectation was that he will live till 70. So 70 minus 62, how many early he died? 8 years early he died. And how many years he lived with hemiparesis? 10 years. So total DALY will be 18 years will be the DALY. Okay. You understand? Two things there. How many early you died and how many years you suffered. So it is 18. In the same question, in place of 62 years, if I say 72 years, you will not add extra 2 years, that he lived extra 2 years, so 10 minus 2 total 8. No, this time he lost 0 year because he lived till 70 and he lived 10 years only with disability. So this time the DALY will be 10. Okay. If we assume life expectancy as 70, then DALY will come 18 year. Okay. Now you understand DALY, I hope. Two things: life lost plus lived with disability. What is Sullivan index, they can ask. Remember the formula, it is life expectancy minus DALY. In our question example, DALY was 18 year. Life expectancy is 70 year in India. So 70 minus 18, Sullivan index will come 52 year. What is Sullivan index telling us? It is telling us year of life lived without disability, without problem. This story which I shared above is the story of my father. In second year of my MBBS, he had hemiparesis. He suffered from it from 10 years and he died 5.5 years back. So, till how much year my father was completely healthy without problem? At 62 year, at 52 year, he developed hemiparesis. He suffered for 18 years. And life expectancy is 70. So 70 minus 18, 52 year. Till 52 year, my father was healthy without problem. This is what Sullivan index tells us. What is the life lost without problem? So without problem lived till 52. How we found it? By doing life expectancy minus DALY. Okay. And you can see I am not very sad while talking about my father death. Why? Because I am a father myself now. I have a girl child of 2.5 years, also a Londa male child of 7 months. But since I am a father, I know that being a parent, we only want one thing from our children, that our children should be happy in their life, whatever they do. And that is why your parents are asking you to clear exams and all, because they think after clearing exam, you will be happy. So their main purpose, their heart is your happiness. Don't listen to their word. See their deeps inside their heart, which is only asking for your happiness. So if you are not happy, if I am not happy remembering my father's death, I am not fulfilling his wish. Na? So I should be happy. Hai na? That is one thing we should definitely try to do, and we should be happy no matter what the situation is. Now, Sullivan index is something which we measure at death, that how many years healthy live. But if I am trying to know it at birth, healthy life expectancy at birth, then we call it hell. Like I can calculate hell for my girl child Prisha Lakshmi, and her hell will be less than hell of a Japanese girl child. So hell is at birth, Sullivan index is at death. Finally, they are asking these exams a lot of question on quali. They will say that in Japan they are doing some intervention to improve life expectancy. Intervention to improve life expectancy. It is an example of which thing? So whenever they use the word intervention, it will be example of quali. Quali means, full form is quality adjusted life year, but we have to remove adjust the adjusted word. So full form is quality life year added due to an intervention. Like Park has written, dialysis add 0.5 quali each year in life of patient. So let's say you want to get fund, suppose Dr. Rakesh Kumar Tiwari want to get fund to help all the renal disease patient in Bihar. So he can go to Mr. Nitish Kumar and can say, hey Nitishwa, give me some fund to open a dialysis center. There are 1 lakh renal disease patient. We will give them 0.5 into 1 lakh, 50,000 quali. And so they will vote for you, their parent will vote for you, their children will vote for you, and you might win the election. Give me the fund. So he might get some fund for that. So I hope you understand that whenever they use the word intervention, it is quali. Whenever they say year of life lived with disability, this is DALI, which has 2 components, lived with disability plus early life lost also, 2 things, year of life lost plus lived with disability. If they are Sullivan index, that is life expectancy minus DALI, it is estimated at birth. Sullivan index is estimated at death, that how many years the person lived healthy. It is Sullivan index is life expectancy minus DALI. And last thing is potential year of life loss is simply how many early you died, how many year early you died. And so this is that area which we usually don't revise and we get confused. That's why in NEET they keep asking it again and again if they have to make the paper tough. And I hope you will not confuse in this part. Now, one area which again come again and again and we do some silly mistake is the level of prevention. So to answer the question from level of prevention, remember the purpose of doing that thing and you will never be wrong. It's like in the recent exam they asked that Indian diet is an example of which thing. So if they're talking about Indian diet or health advice, this is given to general population when the risk is absent, therefore the answer is primordial. But let's say you are telling it to me ki mote daud nahi to phatega. So in my body you can see the risk factor hanging. So in my case it will become primary. And so health advice to high risk person will become primary. So you have to see carefully what they are attaching with it. But if they only ask health advice, where it will go? Primordial. Okay. Now, when they ask about any screening test on any person or any treatment, that will be secondary because secondary is for early diagnosis and treatment. And if they help in making the person self-dependent, that will become rehabilitation or disability limitation, which is tertiary. Like I can ask you the refractive error glass which you are wearing. It is not treating the illness, it is making you self-dependent. So refractive error glass will be tertiary. Hearing aid will be tertiary. Physiotherapy will be tertiary. Caliper, wheelchair will be tertiary. But if I do LASIK surgery is the treatment, it will become secondary. Okay. Now, let's ask some question from this part. If they ask you the question on, like they can ask you the question of Anemia Mukt Bharat. Anemia Mukt Bharat is not for treatment, it is mainly for prevention. So it comes under primary. They can ask question on isolation and quarantine. Both are done to prevent other people who are at risk of infection. So quarantine, isolation, both are primary. Minus desk in school health program, we use minus desk to prevent backache. That is also primary. And let's say they ask minus desk and in the option there is primary and specific both. So you have to tick specific. because examiner think specific as better answer. Okay, and do remember this point. We do quarantine till maximum incubation period. We do isolation till the person can infect other, till period of infectivity or communicability. So quarantine is done on person who look healthy, apparently healthy, and it is done till incubation period. Isolation is done on person with already having the disease till he can infect other. So you can say that, sir, here disease is already there, so it should be secondary. No, because we are doing isolation on the person to prevent other family member who are at risk but not yet infected. So it is for healthy people who are at risk. That's why isolation is also primary. Now, for chemoprophylaxis also come under primary. We do it for malaria. We also do it for filariasis. Yeah. And we can also do it for scabies in the family. We have to give it to everyone. And in vitamin A deficiency, if cataract is, if night blindness is more than 1% and biotic spot is more than 0.5%, then we do it in all 0 to 6 year children. So chemoprophylaxis in malaria, if let's say a UK citizen came to India and went back from India, then the chemoprophylaxis is always done for 4 weeks. Do remember it. But let's say someone came from India and stayed in India for let's say 4 weeks, less than 6 weeks is the stay. Then we give doxycycline. If some UK citizen came and stay for 1 year, more than 6 weeks, then we will give mefloquine if the duration of stay is more than 6 weeks. Okay, so these all are primary or specific protection. Now let's do some challenging question from here. They can ask you the question, BP of a healthy person, under which category it will come? You will think it is healthy, you will answer primary, primordial, but no. Remember it. Why we are taking BP? Purpose is to make early diagnosis of hidden hypertension. And all early diagnosis, early detection come under secondary. Even if I took BP of a 10-year-old kid, in 10-year-old kid, nephrotic syndrome can lead to hypertension. So no matter whose BP I am taking, it is always secondary. Like they can ask, BP taken in a health fair, mela mein ho gaya khela. So in health fair also, purpose is early detection, so it will be secondary. Then they can create this question that they have created it already, that son took hemiparesis father for checkup. Under which prevention it will come? People think it is hemiparesis, they take tertiary. No, remember the purpose. Purpose of checkup is early detection of second attack. So it will be secondary. But if they change the question and ask, son took hemiparesis father for physiotherapy, then it will be tertiary. Because physiotherapy making the person self-dependent. Okay. In NEET INICET exam, they had given you one time image of filariasis foot and someone is taking care of that by washing it and all. Under which category it will come? It will be disability limitation or making the person self-dependent. So it is tertiary prevention, patient foot care. Okay. So these are the level of prevention which they ask. Other than level of prevention, there is one more thing, DIDH. Disease, impairment, then disability, then handicap. So if I ask, where will hemiparesis go? Hemiparesis is loss of body power or part. So if it is loss of body part or power, it is impairment. If they say patient can't walk, can't write, can't eat, some function is gone, then we put disability. And if they say patient lost job, then patient is dependent on other and we put it as handicap. So only lost job is handicap. Can't write, can't read, can't fly, can't walk. All those can't thing will be disability. Okay. And the sequence is DIDH, disease, impairment, disability, handicap. I hope you will remember. One more small thing they ask from here is, this specific protection is the better answer when primary is given, because primary and specific both they think is the same thing, but the difference is specific is method of prevention and primary is level of prevention. That's the difference. But examiner don't know this detail, so they interchangeably ask it, and all primary should be written as specific. What is health promotion? Health promotion is something which include both primordial and primary. Example is mother and child linkage or breastfeeding. For example, to understand it better, imagine me as a lactating mother. So I am breastfeeding my kid. Why I am breastfeeding because it will prevent myself from future risk of breast cancer, and it will protect my child from future risk of diabetes. So it is primordial, because there is no risk of diabetes now. It is future risk. So it is primordial. Now suppose I am again breastfeeding my kid. Why I am beating? Because बीच में काट ले रहा है ना, he is biting my nipple in between, so I am beating. So when I am breastfeeding from the second breast, this time purpose of my breastfeeding is to prevent malnutrition in my kid. If I will not breastfeed today, my kid will be malnourished today. So it is preventing from present risk. It will be primary prevention. So primary from malnutrition prevention, primordial from future risk prevention, diabetes. Both are there. That's why breastfeeding will be health promotion. And a mother-child in case, breastfeeding will be health promotion. Okay. And I still remember my younger sister had a kid, Riddhi. She was very healthy and all. So when she was 1 year old and all, whenever I used to take it, she used to pull my t-shirt down, saying कि मामा है तो तुम्हारे पास भी पिलाते नहीं हो, है ना मामा, you also have the breast but you are not feeding me like that, है ना. अब मैं क्या बताऊं उसको कि it will only hair will come out, ना, no, there is no milk which will come out. She used to think that it's something which I am not giving it to her. Anyway, so this is one thing which you have to remember, the level of prevention. The second thing is they can create very good image-based question on outbreak, epidemics, and they can ask which type of epidemic is there. So remember this point, that if all cases occur in one incubation period, you have to see in such thing the days. If all cases occurring in one incubation period, we call it point source or common source single exposure. And you have to remember 4 outbreaks incubation period to answer such question. Measles outbreak incubation period 10 to 14, hepatitis A 10 to 50, salmonella 1 to 3, cholera 1 to 5. Okay, so maximum is for hepatitis A. So in a hostel, boy hostel, let's say all case of hepatitis A occur in 30 days. It's 30 days, but still it is within one incubation period. You call it point source or common source. Okay, but if the duration is more than one incubation period, then we answer it as common source continuous exposure if the duration is more than one incubation period. Okay. And in continuous exposure, cases will keep on occurring. A very common example they're asking these days is milkman distributing contaminated milk. So the source is common, but case will keep on occurring because he's using the same contaminated water again and again. Okay. Similarly, typhoid Mary, who was a cook, and she was a chronic carrier, so she used to store the typhoid bacilli in gallbladder, and from gallbladder it go to intestine, and then from out pitch. And she was a cook, so she used to prepare flavored food, yellow sandwich, yellow burger. It's like apni to paathsala, masti ki paathsala. And people were dying because of her spreading typhoid to them. So this is again a common source, but people were dying again and again, continuous exposure. Third example is contaminated full batch of polio vaccine, which will keep on continuously infecting others. And one more example will be sex worker transmitting gonorrhea. Do remember these 4 examples, they come under common source continuous exposure, and it will take more than one incubation period. Now, in any question, if they give you an image with a big wave, secondary wave, that is always propagated. And when secondary wave I said, you must have remembered COVID with secondary wave. So secondary wave will occur only in propagated, and that means propagated mostly transmitted by respiratory routes and all. Okay. Secondary wave will occur there, like in MERS, SARS, flu, all those pandemic were propagated. So secondary wave propagated. More than one incubation period, mostly answer is continuous. More than one is also propagated, but propagated is with secondary wave. And within one incubation period, we call it point source or common source single exposure. Okay. Other than this, we can read about secular trend, very commonly asked. Secular are those leader or those trend which are constant. Secular leader is constant to all religion, and secular trend is constant increase or decrease in cases over a long period of time. And they ask the example of secular trend. Example is cardiovascular disease, hypertension, diabetes, because their cases are constantly increasing all over the world from 1950 till now. So this is secular trend. And any kind of trend, if they say trend is represented by line diagram always. Okay. So who is the secular leader of India? And when I asked it in one of the class, students say Modi is the secular leader. I said, you are right, Modi is secular and I am Noora Fatehi. Okay. So do remember the example. Secular trend is cardiovascular disease, which is constantly increasing. So for a long period of time, that's why it is secular. Seasonal and cyclic, I hope you know, if disease is repeated due to season, it's seasonal, like malaria and all. Cyclic, if it is repeated at fixed interval of time, like every weekend there is many accident. Why? Because they drink every weekend. So it is cyclic, not seasonal. Hai na? Seasonal is in, you might have seen in Noida Expressway and all, during winter season, one vehicle do accident and due to fog, then another vehicle also do accident in it. And like fuck, they keep on hitting each other. So that will be seasonal, because here it is due to weather condition. Cyclic is not due to weather condition. That's the difference between them. Okay. So these are some of the concepts. Then they ask the question of iceberg phenomena. Iceberg phenomena means most of the disease patient can recover without symptom. They are the hidden part. This is known as subclinical case. Subclinical are those, remember, who recover without symptom. Recover without symptom. Like in COVID, a lot of patients were subclinical. They used to recover without any symptom. Only when we used to do the test, then we used to know that you are COVID positive. So there are 5 diseases in which no one recover without symptom, like rabies, tetanus, measles, neonatal rubella, pertussis. Okay, no one recover without symptom. Let's say I am bitten by a rabid dog, and after 3 months or 6 months, I will also start barking and biting. For that 3 or 6 months, I can remain hidden, but I cannot recover without symptom. Ultimately, I will develop the symptom after 3 or 6 months also. And whenever I will develop symptom, I will go to the clinic and clinician will count me that, okay, this many rabies case occur. So why these 5 diseases do not show iceberg phenomena? Because in these 5 diseases, subclinical case do not occur. No one recover without symptom. So do remember, they will ask it in a twisted way, that in which disease subclinical case do not occur. Answer is any of these 5 diseases. Okay. These do not show iceberg phenomena. Other than iceberg phenomena, they can give you the question from rule of half, and they will ask, what is the innermost circle represent? It represents those people who have adequate control. Okay. A lot of the 2 exams, they asked the question on tracking phenomena, where they created this question that you measured BP of a patient's group and you found the people with less BP at higher also have less BP at the end. So less BP at beginning also have less BP at end, or more BP at beginning more also have more BP at end. This is representing tracking phenomena. It looks like BP is tracking the person. So why this phenomena they teach us in PSM? Because a lot of parents, they want to make their kid fluffy and all. It's a bad thing to do, because if you make their BP high in childhood, their BP will remain high even at adulthood. So we should do the intervention early. And that's what tracking phenomena say. And they can ask you the image-based question also from here. Then they can also ask you the image-based question from Kaplan-Meier survival plot. Let's say a not so good relative or a Kamina neighbor came to your house and asked that stent and bypass both are being suggested by cardiologists to my relative, which I should do. And you, if you don't know the answer, you can say to the relative or the Kamina rascal neighbor that by looking at your face, I feel like pissing. Let me go to the washroom, then I will come and reply. And go to the washroom and type this thing, that Kaplan-Meier survival plot between stent and bypass. If you will type it, this type of plot will come out. Why I am calling this neighbor as rascal? Because he had already asked the question from the cardiologist. He is not asking to know, he is asking to check whether you know or not. So if this type of image come, what is it telling us? It is telling us this blue line, which is the uppermost, this has best survival. The one line which is on the right hand side has best survival, because in the denominator we are writing year of survival. So this line is till 8-year maximum survival. And here you can see in this image, I have drawn this green light, or let's make it this green light. Let's make it red, a red light. This is for a stent, which is above. And there is one another light. Let's make it some other color, like let's make it black line. Black is here. It is telling us angioplasty, which has lesser survival. Okay, so it compares survival time between any two surgeries or intervention. Now, survival time cannot be fixed. It is always in range. Let's say after surgery, if someone is walking, survival is better. If someone is not walking after stent, survival is less better. So the survival time with stent or any intervention always come in a range. This range is known as confidence band. And there are two types of confidence band: equal precision, Hall and Wellner band. There is one more band, log band. So they can ask the question, which is not a confidence band? Okay, or they can ask, which is a confidence band? So remember, it is equal precision, not unequal precision. Equal precision is a band, Hall and Wellner is a band, and log band are band. And this Kaplan-Meier is many a time used in UK and USA when they are dealing with cancer therapy patient. They suggest that when you do chemotherapy plus radiation plus surgery, this is the survival. And if you do chemotherapy plus radiation only, no surgery, then this is the survival. So you have to choose which survival is better. And they give the option to patient, and the answer is never precise. It is always in band, which is two type of band, equal precision, Hall and Wellner. Okay, I hope this concept is also clear. So these are some of the topics which is there in epidemiology concept, which we have to read. After epidemiological concept, we can also read about epidemiological studies, how to decide which study to apply and all. So in the epidemiological study, one question they have recently asked in INICT exam from the classification part also. And in the classification, you have to remember that if it is interventional, interventional simply means all kind of RCT. When we do it on patient, it's clinical trial, healthy people field trial, community trial. Intervention means we are giving something from our side, it will be RCT under it. Other than RCT, all studies are observational study. And under observational study, if you are just describing the situation, it is descriptive. And example for this is case study, case series. Case study is hospital story of one patient. Case series is hospital story of one or more than one group of patient having common illness, that is case series. So case study, case series are descriptive. Let me give a small example for it. Let's say suppose in our group, someone took surgery. Suppose Dilip Singh took surgery. And on his first duty night, a patient come with penile fracture. So he repaired it and write it in detail. This was the symptom, this was the history, how it got fractured, how he managed it, and what is the prognosis. And then he said, go slow and all, and left the patient. So this whole is written for one patient, that is case study. And case study can also be called as case report. So it is reported as care study, CA from here, RE from here, care report. Okay. Then suppose this one person whose the penile fracture is repaired by Dilip Singh is a celebrity, and now Dilip Singh is famous and he is being called in Delhi to repair 4 fracture, and he is also being called in Dubai to repair 3 penile fracture. Al Habibi. And now he is writing all this thing in detail in a story form. So that will be case series, because now there is one or more than one group of patient, but they have the common story of penile fracture. So case study, case series are descriptive. But when we use data to analyze, that become analytic. Case control and cohort are analytic. And there are 2 studies which are both descriptive and analytic, that is cross-sectional and ecological. Because in them we also get some data which can be analyzed, and we also have some story which can describe. So what is the difference between cross-sectional and ecological? I hope the classification is clear, and I hope you will remember it. The difference is, in cross-section, we measure prevalence by asking question from everyone about present moment. So cross-section is done in present moment, like taking picture, which can only be done in present moment. That's why cross-section is known as a snapshot study. Cross-section only tell about present moment prevalence and the associated factor. And remember, in cross-section, we are asking it from everyone. But in ecological study, like I can ask it from you, do you have cold and cough? Do you smoke? So I am asking it, and suppose 3 out of 80 said yes. That means 3 is the prevalence of cough and cold. And out of that 3, I will try to come and detect whether more are smokers out of these three or less are smoker out of these three. So I will try to associate whether smoking is causing cold and cough or not. So this type of question is cross-sectional, where I'm asking from everyone. But some of you can hide the history also when you start thinking about other people, and therefore in cross-sectional study, apprehension bias occur. The example of that is white coat hypertension. Just by seeing the doctor in white coat, BP of patient rises. Not because the doctor is hot, but because patient is thinking now where will the doctor will put his finger in my body, hai na? What disease will come out. So that is apprehension bias which occur in cross-section. We hide the correct thing or our response changes when we think about other people. Ecological study, as I said, we don't ask questions from anyone. We only collect population data, correlate with hospital data. Like if I said breast cancer in America increase with fatty diet consumption, that's ecological. I am just correlating fatty diet with breast cancer. But this type of statement is not correct for every breast cancer patient of America. That is ecological fallacy. Whenever we correlate hospital and population data, we say something about whole population, and whenever we say about whole population, it is not correct when applied to individual. Like in America, many female will have developed breast cancer not due to fatty diet but due to smoking, due to family history. So it's not correct for every individual. That is ecological fallacy. Now, one very common question they ask is that if a drug does not cure patient but prevent death due to it, what will be the effect on prevalence on incidence? So remember this one trick. Whenever they ask about drug has zero effect on incidence. Incidence always remains same. Incidence always same. And here they are saying they are not curing the patient. Like BP sugar drug, it never cure the hypertension diabetes, it only prevent death. So if BP sugar drug is not curing the disease, only prolonging the illness, therefore duration will be more. And there is this formula that prevalence is incidence into duration. A small numerical has also come in FMG exam on this formula. So do remember this numerical formula. P is incidence into duration. So duration here is increasing due to BP sugar drug, and because duration increases, so prevalence increases. Okay. So remember, if patient is not cured and not dying, prevalence increases, incidence same. But if they ask the question that drug cure disease quickly, cure quickly means duration less. Duration less means prevalence less. But incidence remain almost same. Okay. Now, they are asking some clinical question like this, that what is the most common cancer of female? And this they can ask female of world of India. Recent exam they have asked female of India. A lot of student answer cervical cancer. Remember it. Whenever they ask about female, always the answer is breast cancer. Again, due to the same logic, breast cancer patients suffer for long duration. So at any time, if I am measuring how many are breast cancer people, they will be large in number. But cervical cancer, lung cancer, they die quickly within 1-2 years. So their number will always be less. So most common cancer of female of India or world, breast cancer. And if I ask most common cancer of world, again the answer will be breast cancer. Because lung cancer, they die within 1-2 years. Breast cancer suffer for longer duration. So their count will be always greater. This is given in a table in part, so don't doubt it. And I hope you all know, if they ask most common cancer in male of India, it will be oral cavity cancer, because ऊंचे लोग ऊंची पसंद मानिक चंद बोलो तो बोलो जुबा केसरी, है ना? We are chewing tobacco product a lot, so oral and lip cavity cancer is more common in male of India. But if they ask male of world, then answer will be lung cancer, because they smoke a lot. Okay. Now, case control study, I hope you all know, start with case and control, and we go in past. So if they start with disease and non-disease, with outcome present, non-outcome absent, it is case control. And first we select case and control, disease present, disease absent. Then we do matching. Now they should be, if we are, let's say I am comparing whether COVID is occurring due to contact history or not. And I am choosing in the COVID 100 people between 20 to 25 years. So in control also, I will choose 100 people between 20 to 25 years. This is known as matching, when you choose same type of people. Then I will take the past history, whether you came in contact or not. And suppose in this COVID positive people, out of 199 gave history, because they are already suffering so they will recall it कि कौन कमीना फैलाया मुझे कोरोना, who was that rascal who spread it. They will remember it better. But the people who are negative, they will forget the history because they are not having illness, so they will not emphasize on their brain and remember it strong. So they will forget. This negative will forget, but positive will remember. This will lead to recall bias. Cases remember? Cases remember? Control forget. Recall bias occur in case control study. And due to this recall bias, we got this wrong data by when we put it in 2 by 2 table, we can calculate odds ratio in case control study. And in that odds ratio, we got the answer that COVID is 147 times more common in those who came in contact. And with this wrong data, the whole world applied curfew except Sweden. And when they compared the cases, it was found that Sweden has 1/3 cases as compared to UK, USA, which has very high strict curfew. They have 3 times more cases as compared to those who have very light curfew. So like no curfew like Sweden. So you can understand that curfew or contact was actually not the real thing. So why we got this wrong data? Because one group, the case, they will remember it, control will forget it. And this is recall bias, which is the problem of case control study. So in case control study, when we calculate odds ratio, they can give you small numerical on it also. You just have to do AD by BC. You have to do the cross multiplication. That is why odds ratio is also known as cross product ratio, other name of it, because we are multiplying A with D, B with C. So cross product, not in cross sectional, but in case control study, we get it. Okay. Then after case control study, which is also known as effect to cause, we are starting with parinam, we are starting with effect or outcome, then going to the cause. So you can remember case control as parinam se karan, effect to cause. That is case control. And case control is easy to do for rare disease. It doesn't mean that it is done only for rare disease. It can be done for common disease, but for rare disease, it is easy to do. And do remember, case control is effect to cause. Okay. So now, when it comes to cohort start with cause. So one group is cause present, one group is cause absent. And then we go to the outcome. For example, in cohort study, let's say I am comparing, suppose I am comparing 2 group of people, one who are alcoholic driver, one who are non-alcoholic driver. And I am comparing them that how many accidents they have in next 3 years. So out of the 100 alcoholic driver, suppose 80 has accident, and out of 100 non-alcoholic driver, 20 has accident. So first thing which I can found is relative risk, which is incidence in exposed. They will put in the question incidence in exposed by incidence in non-exposed. By or divided word they gave, that is relative risk, by or divided. So formula of RR is incidence in exposed by incidence in non-exposed. And when you write it in 2 by 2 table, the formula will come A by A plus B by C plus D. But in most of the numerical, you will find that exposed, non-exposed are equal. A plus B and C plus D are equal, so they will cancel out. And finally, you have A by C, 80 by 20 like here, 4 times more accident, you can simply say. So most of the time when they ask you, then recent FMG, they have asked you numerical on relative risk. In relative risk numerical, if this part is 12, this part is 2, and this part is the accident, let's say, if they ask relative risk, it's simply 12 by 2 or A by C. If both are 100, then we can remove them and answer will be A by C. The formula for attributable risk is exposed minus non-exposed by exposed. Okay, because attributable risk is asking us how many extra accident occur due to alcohol. See, 80 is here, 20 is here. How many extra accident is due to alcohol? Not all 80 are due to alcohol, because 20 are anyway doing accident. So how many extra are due to alcohol? 60 extra are due to drinking alcohol. Because 20 will do accident anyway. So extra, if you have to found, you have to subtract 80 with 20, you have to subtract exposed with non-exposed. So that's why in AR we have exposed minus non-exposed as compared to exposed. And if you will solve it, it will come 75%. Attributable risk will tell us how many accident is due to drink and drive. But when we measure PAR, the simple difference is you change exposed with population. Wherever you write exposed, now you write population. Non-exposed and 100 will be same. And AR will become PAR. PAR will tell us that if people stop drinking and driving, how much accident will decrease. So here, if you solve it, it will come 60%. If people stop drink and drive, 60% accident will decrease. So when they use AR, they use the word due to. When they use PAR, they use the word decrease by. How much it will decrease by. Okay. So these are the three things in cohort study they ask. One more thing they ask is incidence rate. Incidence rate simply means total new case divided by person into time. So one of the objectivism they have asked, total new case added over time is known as. So if they say added over time, it is definitely incidence rate. Okay. And as you all must be knowing, in cohort study, there is two more type of cohort on which they are asking a lot of questions these days. Retrospective cohort, which is also known as historical cohort, and mixed cohort. So let's very simply, when they ask question on retrospective or historical cohort, they will give written past data or work record. Like they will say that aniline dye worker has 9 times more risk of bladder cancer as compared to office staff. This data we get by comparing their work record of last 20 years. Which type of study is here? So when they have written the word past work record or written data, answer is retrospective cohort, historical. But let's say they write that along with past work record, there is also future follow-up. Then it becomes mixed cohort. Mixed is also known as ambispertive, and it is also known as nested case control. There are 3 names for it. So nested case control, all these 3 are together. So you can remember all these 3 by the mnemonic MAN. And when they will ask question on these 3, they will give both the thing, written past record or work data plus future follow-up. If both thing is there for future follow-up and past record, then it is mixed, because now it can go past and future both. Now it is ambispertive because in both direction. And why they call it nested case control? Because the main hard work is future follow-up, in which we are inserting the data of past. तो पास्ट ने केस कंट्रोल ने कोहॉर्ट में घोंसला बना लिया है. Nested, we are nesting or inserting the data of case control in cohort. That's why it is nested case control. So with the help of mnemonic Rh positive man, because we know erythroblastosis fetalis occur if man is Rh positive, woman is negative. So with the help of Rh positive man, we can tell which type of study is done. In Rh, there will be written record. In man can go both direction. So there is past record plus future follow-up both. Okay. So let me give you one example which will clarify it. Suppose someone in your batch, let's say his name is Ashwini, he worked really hard and he got radiology branch and all. Now he's giving a big party. And a neighbor of Ashwini, let's say his name is Majnu Bhai, came to the party and say, hey, why are you doing the party? Don't you know that risk of tetanus cancer, testicular cancer is 1.2 times more in radiology staff as compared to other staff based on work record data of last 10 years. तो तेरे टट्टे खतरे में है और तू पार्टी कर रहा है. Your testes are in danger and you are doing party. So what he is saying based on work record data, radiology staff has 1.2 times more risk. So which type of study he is doing? Retrospective or historical. Now suppose Ashwini took radiology, and when he took it, he started doing 3-year cohort study and compare radiology staff with other staff, and he also used data of last 10-year work record. So then this is mixed cohort, ambispertive, nested. And finally it will come that the risk is almost negligible. Okay. So mixed means both. RH means only past record. I hope this session would have clarified your some of the doubts and might have helped you in understanding some concept better and definitely help you in revising it. In the next session, we will read the biostat which is left, summary of that, and some other topic. On Wednesday, probably I will have one more session of around 2.5 hours where I will revise all the remaining topic, and then your PSM revision will be done in this 2 session. I am truly happy with your response and replies. Thank you so much for it. Keep enjoying the journey. Keep reading it well. And keep doing PYQ. Your 9 to 3 timing should be for PYQ and their explanation part. Revise them again and again. That will give you a very good jump in marks. Okay. And then read those topics in the theory part. Thank you so much. Love you all. If you have any doubt, anything to say, feel free and tell me. Acha, one junior surgeon is saying that, sir, can you also take lecture on all the incentive given in health program and health worker from page 24? Incentive given to all health programs and health worker. Okay, I will include it in my next class on Wednesday. I will tell you on the incentives to ASA and other people. Chota Doctor is writing that most common cause of anemia in older women is iron deficiency anemia or anemia of chronic disease. In older women, menses loss is less. So they mostly develop it due to some chronic disease and all, many a time. But I need to check the prevalence and then give you the exact answer. I don't know the exact answer, so I will let the question go and I will answer it in my next session on Wednesday. Chota Doctor is saying your example are very good to understand. Unlike other teacher, they just read theory. You explain with example. Thank you, Chota Doctor. I love you, bro. I love you. Meenakshi is saying, thank you, sir. Please take next session as soon as possible. Okay, I will take it on Wednesday. Deepak is saying, INICT PYQ discussion nahi hoga, sir. Deepak, you are the one who always keep me on track. So Wednesday is one last revision session so that we can finish it. On Thursday, I will have INICT PYQ revision in Hindi. Okay, on Thursday. On Wednesday, there is one more revision session. On Thursday, INICT revision in Hindi will be done. Okay, Deepak, your wish is my command. In between, I went to take some classes otherwhere, so I did not fulfill it, but I will have INICT PYQ revision as well. Thank you so much. Bye-bye. Love you all. Thank you.